From the time they are born, children with cleft lip and or palate face many challenges. They struggle to eat, breathe, speak, and even survive. Treating cleft lip and palate requires a range of long-term, comprehensive cleft care interventions. But around the world, there is a severe shortage of medical professionals with the skills or resources necessary to provide this specialized care. This is why SmileTrain, as part of our sustainable partnership model, offers a variety of innovative training and educational resources to cleft care providers around the world. For over 21 years, we have partnered with cleft care professionals at more than 1,100 hospitals in over 90 countries, offering more than 40,000 training opportunities, a number that is growing every day. Over the coming years, SmileTrain will scale these programs and resources because we know that behind every smile, there's a team of healthcare professionals who made it happen.
All right, hello.
Maraming challenges rin na pagdaanan ko. Nandiyan yung tinutoksokan, yung bata ka. Siyempre, ikaw, nasasaktan ka, di ba?
Hindi ko sila lang sinasabi kay mama, pero may times na binubuli pa rin ako. Halos araw-araw yun, pagpapasok ko sa school. Tapos, nasa rin ka nila ng bingot, gano'n. Tapos, halimaw.
Mga classmate mo, ina-assure mo ako. Ina-assure mo minsan, ina-assure mo ako. Mananalalasat mo ako, tinatawanan mo ako.
Nung baby na po ako, akot po nilang parang i-opera po ako. Akala po nila parang, mamamatay na nun po.
In the Philippines, there are about 5,000 babies born with a cleft lip and or palate annually. Cleft is far more than a cosmetic problem. Children with untreated clefts not only live in isolation, but also face physical difficulties with eating, breathing, and speaking. As a result, most of them don't attend school or ever hold a job. Cleft repair surgery is safe and the transformation is immediate. SmileTrain is the world's leading cleft charity that supports comprehensive cleft care, including surgery, orthodontics, dental services, speech therapy, nutrition, and psychosocial support. SmileTrain's sustainable model focuses on training local medical professionals in more than 90 countries to perform cleft repair surgery and comprehensive cleft care in their own communities. They then go on to train others, creating a long-term, sustainable system.
Kung hindi ako na-operahan, siguro baka wala ako dito ngayon. Baka nasa bahay lang ako, nagtatago.
Magiging normal na rin yung buhay ko, yung wala nang manlalait sa akin.
Masaya po, maayos-ayos ako, makakapunit po kanina po natin.
Ngayon po, nakakangiti na po ako. Natutunan po ng SmileTrain.
Cleft repair surgery may take as short as 45 minutes, but the impact is life-changing. Former patients have the opportunity to attend school, get a job, start a family, and contribute to the society at large. Refer someone in need today and give the gift of a smile and a second chance at life.
All right, so thank you very much. Again, we welcome everybody to this second day of this two-day webinar on the screening, triage, and referral of children with cleft lip and palate who are affected by acute malnutrition. And it is our pleasure to be here as part of Kalusugan na Mag-ina and partnered with SmileTrain. And rejoining us today for this afternoon would be Dr. Maria Ascension Silvestre, President of KMI, as well as Dr. Rene Andrew Buku, who is a consultant as well with KMI. So again, we welcome everybody to this afternoon session and hope that you will find the sessions to be as exciting and as fun. And of course, that you are able to pull a lot more knowledge that you will be able to use in your day-to-day practice. So just to start the ball rolling then, I will start this lecture. Again, my name is Dr. Donna Capili. The first slide, oh, sorry, I have to read the house rules. I'm sorry. I did not see that straight away. So for the house rules, there would be an open forum at the end of all the lectures, not per lecture. And so please utilize the Q&A tab for your questions. You will find that at the bottom of your screen. And there will also be interactive poll questions or assessments during the lectures themselves. So please do join us and participate, and it will make our learning all the more fun. So I hope that, again, as I said, that you would be quite engaged for this afternoon. So I guess next slide. Okay, so this is where I was getting at earlier. So to start the ball rolling, this is our first lecture for this afternoon. It covers the screening, triage, and referral of children who have acute malnutrition. So from yesterday, our discussions were basically about the general concepts of undernutrition, and then we honed in on this problem that affects children with cleft lip and palate as well. And then we also put the spotlight on the general context of acute malnutrition in the population. We emphasize that this need for awareness and also the need to integrate screening for malnutrition routinely across the regular programming of our health services. We need to be able to identify these children. So this now leaves the question of what happens after they are identified with acute malnutrition, be it the form of moderate or severe acute malnutrition. So we will now pick up from where we left off yesterday and talk about triage and referral. So for our learning objectives this afternoon, we will describe community mobilization, explain the process of community engagement, and describe the process of developing key messages and community sensitization. We will also screen and identify MAM and SAM. We have very interactive sessions on that. And then learn the indications as to when to refer to targeted feeding supplementary programs, or TFSP, and also to OTC, which you got acquainted with yesterday. This is outpatient therapeutic care, or ITC, which is inpatient therapeutic care. And then also learn the initial medical management and stabilization as needed of these patients prior to the actual referral and admission to either OTC or ITC. And also to refer a patient for the indicated nutritional treatment. So next slide, please. So if you recall from yesterday, we mentioned, as I said, that an integral component of the approach in the management of acute malnutrition is involvement of the community. So community mobilization is really a vital part in the management of MAM and SAM. And so together with the community members' heightened awareness, affected children will be found more easily and in a more timely manner. The community will also be empowered to act on their behalf. And the aim really in mobilizing community is to find every child with moderate and severe acute malnutrition and protect him or her from further deterioration or death. So next slide, please. So if you think about it, community mobilization is really essential in any program. Take, for example, the advocacy for the timely detection and treatment of cleft lip and palate. So it just so happened that I came across this particular study. It's a survey about the barriers to cleft lip and palate repair around the world. So this survey was actually done among Smile Train partners and looked into barriers for surgical repair. And this was published out in 2016. So if you would find the top 3 barriers that they had surveyed from 1,997 healthcare providers who are partners with Smile Train, the top 3 barriers include patient travel costs. As you know, as we all know, Smile Train helps those who are less fortunate. And so these patients will be definitely affected by the social determinants of health. But then coming in at second is a lack of patient awareness about cleft lip and palate. So something that which you can actually see. So knowing this cause then of lack of patient awareness would have led to solutions to address this problem. And so one such solution is community mobilization. So next slide, please. So for community mobilization, how do we go about it? So there are actually two stages. If you look at the figure in your screen, there are actually two phases. So the green one is the planning phase, and in the orange is the implementation phase. So in the planning phase, this will include stages of community assessment, community dialogue and sensitization, as well as developing key messages and materials, and the training of community healthcare workers. In the orange boxes, these are actually encompassing the implementation phase and will include case finding and referral, follow-up of cases, and recording and reporting. So basically, the bottom line really is to get community engaged by promoting a common understanding of, in this case, acute malnutrition. Key here really would be timely detection and the referral of children with either MAM or SAM. And hopefully this would be prior to the worsening of their condition or their deterioration. There's also emphasis on the importance on the continuity of treatment, because usually there's failure to compliance. So part and parcel of community mobilization is not just the awareness to screen, but also the community's own awareness in as far as what would treatment entail until a child is actually cured from acute malnutrition. So these efforts should be linked with other community initiatives. So next slide, please. So in as far as community assessment is concerned, the aim really is to understand what are the existing capacities in health, nutrition, and also the level of community awareness. It may involve conducting a series of interviews or focus group discussions just to really touch base with what is the information out there in the community. Next slide, please. So what are the elements of community assessment? You can see these boxes are numbered 1 to 9, and these are pretty much the information that we want to glean from all these discussions with the community. Of course, in order to be able to communicate well about acute malnutrition, in this case, we need to know what the local perceptions are. How do they actually identify, or how do they, what words do they use in order to label what acute malnutrition is. So it's also very important to learn what the attitudes are towards illness and malnutrition, and what are the usual health-seeking behaviors. There are a lot of cultural factors as well that would impact on what would be the pervading beliefs and practices in the community relating to feeding and nutrition of young children, for example. And it's very important to dialogue with the community about MAM and SAM treatment and services. So it's not merely you on the health provider's side. There has to be teamwork between the so-called provider and also the demand side. In this case, this is represented by community. So there should also be opportunities to access children at the community level for the identification and follow-up of severe cases. And this goes back to what I was saying earlier, that it really should be a must that screening for acute malnutrition should be integrated into routine follow-up care of children. It's also worthwhile to note what are the existing nutrition and health interventions that are being practiced in the community. For example, infant and young child feeding programs. Here in the Philippines, we have the Operation Timbang Plus, Garantisadong Pambasta. So these are all things that we want to glean from the community during this assessment. So next slide, please. All right, so the information that we get from the assessment will be used to develop a sensitization plan. So here in the Philippines with PMAM, essentially the group that is charged with this responsibility is the local government, and they will partner with advocates who are also pushing for the early detection and treatment of acute malnutrition, as we are illustrating. So this plan, once it is actually developed, should be reviewed with the community. Community could be represented by influential persons among their ranks. Also, this is to check, whether the plan is culturally appropriate. In the Philippines, for example, there are a lot of indigenous groups. So it will be best to check how culturally sensitive these materials are. So after the program has started, it is always good to start a community dialogue, continue that discussion so as to continue to escalate the awareness that the community has about acute malnutrition in both its forms. So next slide, please. So we're talking about sensitization, getting the word out there. So typically, like right now with the age of the internet, there's a lot of information overload that we have, just at within your fingertips, at the click of your keyboard. So, but we need to get out there true facts, not fake news. So we need to get out the true facts about, in this case, as I said, about acute malnutrition. So we need to put in information about signs and symptoms for the community members to be aware. And then what is the importance of treatment? And perhaps for the more savvy community members, they may be able, they may also want to know about the identification of acute malnutrition in either moderate or severe. And then also give information as to, in this case, the program, who is it targeting? What age group would be eligible for the program? And then where to send these patients that are, thought to be with acute malnutrition in the community, and who should they consult with, and what to expect during the treatment, and then the need for regular compliance. And then of course, we're talking about normal times, but we're very much aware about how much the degree or the prevalence of, or incidence rather, of acute malnutrition rises during times of emergency. So there should be that heightened awareness as well among local government, but also in the community. But that treatment will be available in the community setting as per indication, or in the hospital. Next slide, please. So this is just a sample of a poster, community sensitization material, if you will. Usually in our face-to-face workshops, we would have participants make their own community sensitization posters. So this is one limitation that we have in a webinar format. But in this is just an example then. So you have a poster here that mentions what could present as malnutrition. So it says here, payat, butot balat. So excuse me for our foreign participants, but these are all in Filipino. It says sakitin, pandak. So these could very well be the terms that are used in the community to potentially describe a child who has malnutrition. And then it says here, baka yan ay malnutrition. And then may bawet, It says here, ito ay nagagamot. So malnutrition, it is potentially curable, And then there is information as to where to get help, and how is that accessible. So I just thought about the fact though that, given that the survey result earlier that I mentioned that a barrier towards surgical repair is the lack of awareness. So a child with congenital cleft may be missed out due to the lack of awareness, but due to community sensitization about acute malnutrition, that child may be potentially screened and assessed and referred accordingly, primarily for the malnutrition and maybe not even for the cleft itself. Just food for thought. So next slide, please. So still in the planning stage, as you can see the boxes on the right lower hand side, you have the green box, and encircled there is the fourth green box. We're still at the planning stage, and it's very important then to train our health workers so that they can also then correspondingly mobilize community. So in the Philippines, health workers would be mobilized, no? Coordination would be routed through the barangay or city or municipal nutrition committees. The health officers of the local governments, as well as the nutrition action officers, the public health nurses, as well as supervising midwives, should ensure that, you know, the community rendering healthcare providers, you know, those that who render service at the community level, at the grassroots, like the barangay nutrition scholars or the barangay health workers and other community volunteers, are actually then trained in how to engage the community and disseminate the sensitization messages so that there would be the early referral. No? Well, first of all, it's identification, then referral of these children with acute malnutrition. Next slide, please. All right, so the next stage then is implementation. So done the planning, done the training, so now it's time to act. So the very first thing to do is really case finding. So this is to ensure that children are screened regularly so that there is identification of acute malnutrition in the early stages when it is still most easily treated. No? Again, the emphasis is integrating routine screening for malnutrition in the quote unquote well child follow-up of children, or even for children who present in the sick clinics. They should also be routinely screened all the more. You know? So in the Philippines, barangay nutrition scholars and barangay health workers are primary level community workers, and they can act as the focal point for all the other people who are mobilized in the community. So, and they could be the first level, no? The front line, as so to speak, no? And as far as screening for these children with acute malnutrition. So you have their types of case finding. So you have active case finding wherein the barangay health worker or the barangay nutrition scholar, the midwife, actually goes to the community to find cases of either moderate or severe acute malnutrition. So they will directly go to the house because they've been tipped off, no, that there is a child here who may have acute malnutrition. And then you have passive case finding, which Dr. Mian doesn't really like to use. She would like to use opportunistic case finding. This is the time wherein children will actually come to a health facility for other routine care, for other health services. But then because of the routine screening for all, then the case of acute malnutrition is picked up, no? So earlier. And then you have an active adaptive case finding wherein instead of going house to house, a community level worker such a barangay health worker or the barangay nutrition scholar may then go to her catchment area and visit every third or every fifth house just to ask the parents there or people in the village if they know of any children in the neighborhood who they may suspect to have MAM and SAM, because they've already had that heightened awareness due to the earlier efforts on community sensitization. So next slide, please. Again, so this is just to ground us on knowledge that we've already hopefully gained from yesterday. And you will see these slides repeating throughout the day. And this is just really for the sake of integrating this into our gray cells. So again, this slide shows us the classification of acute malnutrition for children over 6 up to 59 months. And this is based on the MUAC, or the mid-upper arm circumference, on the weight for length or the weight for height, Z-score, and edema. So if you look at the MUAC, again, the cutoffs being that for SAM, Measurements less than 11.5 centimeter, that would be consistent with SAM. And then MAM, it's in the middle in yellow. So that's 11.5 to 12.4 centimeters. And then what would be considered normal would be 12.5 centimeters, equivalent to it and above. Okay, so and as far as weight for length or weight for height Z-score is concerned, for SAM, less than -3 standard deviations. For MAM, again, in the yellow box there in the middle, so less than -2 to less than -3 standard deviations. And for normal, it is -2 to +2 standard deviations. For edema, it's SAM when it's present. And we're talking about the edema like Dr. Drew had explained very thoroughly yesterday. It's bilateral edema of varying grades depending on how severe the affectation is. I hope you still recall how to check for bipedal edema. Okay, next slide, please. So this slide then shows us the classification of acute malnutrition for infants, those who are less than 6 months. We don't use the MUAC yet as a standard, but we will get enlightened further on potentially the use of the MUAC for the less than 6 months old in the lecture following this. So again, weight for length, Z-score, weight for length, because you have a baby that will only be lying recumbent as you measure length, not height. You can't stand them up. Hope you recall that. So it's the same cutoff levels. And then for edema as well. So you look and check it. If it is present, then the child has severe acute malnutrition. So next slide, please. All right, so now you can identify SAM and MAM. These have been drawn from the lecture since yesterday. And so now the next step would be where to send the child to. Will the child have to go to OTC or ITC in the case of SAM, or will the child have to go to TSFP in the case of MAM? So I think I will stop here at this point and hand you over to Dr. Mian Silvestre, who will then discuss with you, the patient flow pathways when it comes to where to refer the patient with moderate or severe acute malnutrition. Thank you.
Thank you, Donna. And I'd like to say hello to everybody that came back or new participants that came in today. So where are we now? For a sort of interim summary of where we are, yesterday we learned about the gravity of this burden of acute malnutrition. We also learned how anthropometric measurements are done, weight, height, and even the fundamental determination of age in months. We reviewed that. But we also learned how to interpret these anthropometric measurements together in plotting of Z-scores, and went beyond that to interpret the cutoffs for these Z-scores in terms of acute malnutrition, whether severe, moderate, or no malnutrition. What we talked about yesterday was basically identification of the child with acute malnutrition and in the community, in the population that we are targeting. And this morning, we understood from Dr. Donna that the context of this screening, where it is done, how we need to start with what they have. And what they have, as mentioned, are routine health programs like Operation Timbang, like pregnancy tracking, even where community volunteers, our barangay health workers, and our barangay nutritional scholars, they actually go house to house already. So in the identification of acute malnutrition, we would like also to embed within them our identification of cases with Clefts. So for example, if a case of acute malnutrition is detected in the community, either in the course of conducting Operation Timbang or house-to-house surveys, then what would you need to look for? So next slide, please. And how do you decide from there? What we will see next are what are called algorithms. These are simple job aids that will help either community volunteers like BNSs and BHWs, our health workers, and nutrition scholars, our workers, to give them at their fingertips, so to speak, decision aids, simple decision aids that are answerable by yes or no, which take you to another action. Okay, so let's have a quick orientation as to how to interpret these algorithms or decision pathways or clinical pathways. No, when you see, if you see the red dot there, the red spotlight, if you see a rectangle that denotes or connotes an action. Okay, so in this rectangle number 1, the first action always is introduce yourself. Okay, always introduce yourself, and before handling any patient, always do proper hand washing, both to protect the patient or his or her caregiver, and introduce yourself so that you can proceed to taking the history or the story or the narrative of that patient, and to also handle that patient in what is called a physical exam or PE. Okay, only then can you do the anthropometric measurements and edema tests that were described yesterday. Okay, so proceeding down to a hexagon, the 6-sided figure, hexagons connote a decision point. So usually within the hexagon, you will see a question. Like for example, in the shape number 2, the hexagon, the question is there SAM? Is there presence of SAM? So all hexagons are followed by either a yes, connote here as Y, or a no. Okay, so it's always a dichotomous answer, either yes or no. And it proceeds down either to another decision point, another hexagon, or an action. For example, if you proceed to the right side, and yes, there are medical complications. If you proceed to the right, then you will need to do triage. Okay, so triage meaning an assessment of the complications, so that you have a ranking of severity, okay, of urgency. Okay, so these are the 3 basic shapes. There is another shape, for example, a oval, denoted there in shape number 10. An oval signifies or designates a clinical status, okay, and or a link to another algorithm if such are available. Okay, so having said that, we have rectangles as action steps, hexagons as decision points, and ovals as clinical states. Okay, so let's look at this big or overall algorithm for the screening, triage, and referral of acute malnutrition, whether that patient was detected in a routine operation timbang or community assessment, or in a purposive or an active screening of cases for, let's say, cleft palates. Okay, on the right are a listing of all that we talked about yesterday, the criteria for severe acute malnutrition. You have there the cutoffs, the criteria for moderate acute malnutrition or MAM, and then the definitions for outpatient therapeutic care or OTC. Anything that's indicated in any of the shapes is described in a footnote. So what is clinical deterioration? What is inpatient therapeutic care or ITC? And what is recovery? Okay, so can we have the next slide, please? Let's dissect. Okay, so this is our algorithm. I just moved the title to the right side. Let's look at when there is SAM. What I mean is, if the answer to shape number 2 is a yes, let's look at where it takes us. So next slide. Okay, so if the answer to shape number 2 is yes, in other words, SAM is present, because the eligibility criteria for SAM in the footnote are present, then you proceed to ask yourself, are there medical complications? Okay, by medical complications, you will learn that the most common ones are pneumonia, for example, acute gastroenteritis or diarrhea, which are the top two most common medical complications, and with them other further complications like shock or hypothermia, their temperature being very low or their temperature being very high, or dehydration. So these are other further complications of those most common two infections, pneumonia and acute gastroenteritis. When you find any of these complications in patients, the next thing to do would be to assess the urgency of these cases as to whether they should be emergently referred to a health facility. And because it's a complication, we have learned that these patients have to be managed on an inpatient level, meaning a hospital. And thus, these patients are referred to an inpatient therapeutic center. So that's down the line to the rectangle here, colored red, to designate the urgency of that situation, okay? We did not include the various phases, phase 1, phase 2, stabilization, transition, that we learned about for inpatient therapeutic care, but we hope maybe to whet your appetite for another webinar on the actual management of these cases. But we are restricted by time here, the duration of this webinar, to only talk about screening, triage, and referral, so that we can ensure we can locate these patients in facilities that can offer quality services for acute malnutrition, okay? So for this leg, we talked about the cases in which SAM is actually detected or identified, and where as a health worker, you must take these patients, okay? So we talked about, yes, there is SAM. Yes, there are or is a medical complication. Yes, we need to triage and decide as to the urgency of that case and refer to an inpatient therapeutic facility because of these medical complications that put patients with SAM, if you will recall from yesterday, at 9 to 12 times higher risk of dying, okay, because of the underpinning of acute malnutrition in these cases, okay? Next slide. Let's go to the other section of the algorithm when there is no SAM detected. Okay, next slide. There is no SAM detected. Your next decision point should be, there is no SAM, but is there MAM? Okay, so going down to shape number 8, which is another hexagon, you would proceed to look over the patient's anthropometric measurements again. What is the Z-score? Okay, what is the MUAC? Is there edema, etc., etc.? Okay, so but automatically edema would make that patient SAM. Okay, so we're looking now at this portion of the algorithm that has been zoomed out for you. If the patient is a case of moderate acute malnutrition in hexagon number 8, yes, then we refer here in the Philippines to what are called targeted supplementary feeding programs, or TSFP. And here is where, at the current time, at least for the guidelines that were drafted in 2016, there is a special commodity used at that time for the TSFP, and these are the ready-to-use supplementary foods. Okay, so but we can talk later about these special commodities for MAM. Okay, when these special commodities for MAM like TUSP are not available, then we have also alternate recipes that have been developed by our UN agency, the World Food Program, okay, for moderate acute malnutrition. So these targeted supplemental feeding programs that are administered at either maybe municipal or provincial levels, then we are talking about targeted as opposed to blanket feeding programs targeted feeding programs for children with moderate acute malnutrition using the investments made to buy these special commodities, or for a feeding program that includes the preparation of these recipes. Okay. Going from hexagon number 8, if there is no ma'am, you don't just drop the patient and ignore the family. You continue counseling on proper infant and young child feeding practices as we know them, correct? Exclusive breastfeeding started within the first hour of life, continued on up to 6 months, at which time appropriate, preferably indigenous, locally available complementary solids are started, while breastfeeding is continued up to 2 years or beyond. So this is the global strategy for infant and young child feeding, the practices of which still really need to be pushed. Okay, there are many misperceptions and irregular practices that are still prevalent among our communities and our families. Okay, so not only do we counsel on proper infant and young child feeding practices, but we also get them into the vaccination programs at the local health facilities, and also into the other programs for micronutrient supplementation and multivitamins. Okay, so next slide, please. All right, so what do we have to look out for in the age group from 6 months to 59 months, or under 5 years of age? Okay, so these are the indications for a patient with SAM needing admission or referral, I should say, to an inpatient therapeutic care center. Okay, so if the patient has been diagnosed to have SAM, okay, and also fails the appetite test. Yesterday, we said that the patient cannot take 3 or 4 mouthfuls of RUTF or breast milk, or cannot sustain breastfeeding, okay, fails the appetite test within 30 minutes or at the longest 1 hour duration, okay, or the patient has any of the listed medical complications that you see on your screen, okay, for example, intractable vomiting, so that the patient cannot keep in any fluids, whether it's breast milk or solid feeds. The patient has intractable losses from vomiting, okay. The patient has hyperthermia, so to speak, or fever. They're defined as 38 degrees Celsius in the armpit or axillary, or 39 degrees Celsius rectally, or the opposite, which is more common in young infants, hypothermia, very low temperature, defined as taken from under the armpit, a 35 degree Celsius cutoff, or rectally 35.5 degrees centigrade or Celsius, okay. If there is anemia, that is considered a sign of a medical complication. If the patient has very extensive superficial infection of the skin, okay, so many of these patients with acute malnutrition have what we used to call flaky dermatosis. No, they look like they have their skin is sloughing off. If the skin has become superficially infected and it looks like this cannot be managed by oral antibiotics, then that's one reason for the patient to be referred to a hospital. If the child or infant has an altered alertness, is lethargic, cannot be awoken, has no spontaneous movements, okay? If he's dehydrated, and we'll talk about the signs of dehydration again later, and if the breathing is fast, if the patient is called tachypnic, okay, and in pediatrics, it's not just one cutoff, but these are the cutoffs for the various age groups for what we call tachypnea or fast breathing. For babies 6 to 12 months, is more than or equal to 50 breaths per minute for infants or young children 1 to 5 years of age. The cutoff is 40. For over 5-year-olds, the cutoff is 30 and above. Or if none of those breathing cutoffs are exceeded, but if there is evidence that the child or young infant is working too hard at his breathing, what do we mean by that? Working too hard means using other muscles, especially the muscles in between the ribs, to be able to draw air into the lungs. Then these patients, even though they're not breathing fast, this indrawing of the chest, or what we might be more familiar as with as retractions, if the patient is pulling these accessory muscles to pull in air to their lungs, then these patients might tire out, might fatigue at their breathing, and should be referred for oxygen or breathing support. So these are the criteria for referral to inpatient therapeutic care for infants more than 6 months to 59 months of age or under 5 years. Next slide, please. How about if the child or if the young infant is less than 6 months? We have here, we constantly remind each other of the cutoffs for normal, the cutoffs for MAM and for SAM, but what in these clinical conditions of the children constitutes indications for referral to a hospital or an inpatient facility, okay? So for the less than 6-month-olds, what do we look out for in addition to these anthropometric measurements? It's recent weight loss, okay? Sudden weight loss, which most probably might be either dehydration or like we said, intractable vomiting, inability to keep down fluids or food, okay? The inability to gain weight. Any of the medical complications that we talked about for the older infants and young children, any medical issue needing more detailed assessment or intensive support. So here comes our children with clefts, for example, that have severe, that have feeding or even breathing difficulty. All the more the patients who have syndromic cleft defects, what we mean is that their cleft is just part and parcel of a larger constellation of congenital deformities, no, that puts them at risk for developing these medical complications and or death and disability. Okay, so here is where it is best that children less than 6 months old who might not have a overt history of difficult feeding, this is very in these patients less than 6 months, it's all the more important, no, to take a look at that palate, okay? Recently we were called to take a look at an infant who was acutely malnourished, and there didn't seem to be anything amiss, except that at birth, the cleft palate was missed, and it was a cleft palate of the hard palate, okay, and the soft palate. Why was it missed? Because nobody remembered to ask the mother or to try to make the baby even cry, no, with one or 2 second inspection, visualization of the palate. When a baby cries, you can already see obvious clefts of the hard and the soft palate. It's very important that you observe a breastfeeding in these infants. Why? You not only look at how the baby is attached or latched onto the breast, you also listen to the sounds that emanate from the baby suckling, okay? We do emphasize all the time that breastfeeding, when properly attached, is quiet, it's silent. And the only sound that you might hear is the sound of a baby swallowing. When the breast milk has attained a volume enough for a baby to gulp and swallow, then you might hear these gulps and swallows when the baby is suckling adequately. When you hear smacking okay? When you hear smacking, I don't know if you can hear that, okay? It's cute, but these labials, these smacking sounds come from the labial structures, okay? The structures of the lip. And when you hear a baby smacking, then he's either improperly attached or unable to form that closed seal onto the breast, okay? When you hear a baby, when you observe a baby breastfeeding at his mother's breast, and you hear a clucking or a clicking sound, when you open the mouth or when the baby cries and you can't see anything, then think there might be a submucosal cleft, okay? What is that? A cleft of the smooth muscles of your soft palate, no? So there are many things that you can detect just by observing a breastfeeding at the minimum of 4 minutes, listening, asking the mother how she feels, okay? Positioning a doll probably and asking the mother to correct her position and then asking her, did that correct the pain? Okay, so all of these we taught in our first webinar, and we continue to teach to our mother, training our mother support groups and our mothers themselves as to how to detect these feeding difficulties and probably underlying defects of the mouth and the palate, no? Um, to be able to understand, let's say, why a baby who's even as young as less than 6 months already has developed acute malnutrition. Okay, so if a baby with SAM is lethargic, okay, what does that mean? He's difficult to rouse, he seems very sleepy all the time and doesn't move spontaneously, okay? It has what we call commonly as poor suck. He's unable to suckle. Despite your exhausting all the options for breastfeeding using donor milk perhaps, or even pasteurized donor milk, or even suckling at another woman whose volume of breast milk is satisfactory already. If you've exhausted all these other options for either direct or donor breastfeeding, then you also look into maybe the mother or the primary caregiver in most circumstances might be the crux of the matter, the difficulty, okay? So you always, in many of our succeeding slides, we're going to talk about screening for maternal health. Next slide, please. All right, so once you've detected these babies and they've satisfied the criteria for SAM, especially if they manifest with these problems, lethargy, hypothermia, most commonly, poor suck, and other signs of dehydration, what is the first thing that you need to do when you are triaging? Okay, so you don't need to do a full physical examination and take the history while the baby slowly deteriorates in front of your eyes, correct? It's very, very important that, considering that the baby has acutely developed malnutrition, then you should give a source of sugar or glucose, okay? And what is this source? Here in our slide, we say give 10% sugar water solution immediately to a baby who is obviously sick to prevent dehydration and extremely low blood sugar levels that might cause maybe irritability or even convulsions or slow further lapses in his consciousness, okay? What exactly, how do we exactly prepare a 10% sugar solution? You can do this by taking 1 tablespoon. So even if you're in a household, 1 kitchen tablespoon of sugar. You might ask what kind of sugar? Any sugar, brown, white sugar, just not artificial sweeteners, but brown or white sugar. Dissolve it in 100 ml of water. It doesn't have to be perfectly exact, 10 grams, but take that 1 tablespoon. And if the baby is even semi-awake, you can safely, with the baby in upright position, as you see there, so that he doesn't choke or aspirate, administer the 10% sugar solution, and you will slowly see that the baby will perk up, okay? And then at least stabilize that baby enough for continuing on to your physical exam and the history taking with your mother, okay? If you cannot find any sugar in the immediate vicinity of where you are, then there are fruit juices that are very sweet as it is. They're found in Tetra Paks or even a coconut, maybe coconut water. You can use these sweet solutions to help the baby perk up. Next slide, please. All right. Again, there are many pediatricians, many health workers in this group. It's still the dictum of airway, protect the airway. If the baby has vomited, make sure that nothing is obstructing his mouth or nasal cavity, okay? Support breathing if necessary, using, here you see an ambu bag, okay? And support his circulation if you have the means to do so. But very importantly also, remember to provide warmth. These babies are commonly hypothermic with low body temperature. So they need to be wrapped, and if necessary, provide an external source of heat. But if not, then put the baby or the young child in skin-to-skin contact with his mother or other family member, okay? So ABCs still. Next slide, please. All right, so this is the checklist. Administer emergency care as necessary. We have a checklist here. Check for hypoglycemia. Administer the 10% sugar solution in babies who are obviously sick. Provide warmth for hypothermia. Dehydration and hypovolemic shock, we will talk about again in another slide. Feel for their pulses, for their heart rate, etc. The hypernatremic dehydration, babies have a different sort of doughy, cold, clammy consistency to their skin, okay? Septic shock, a lot of times you will assess because of a history of infection that has been neglected probably without any medical attention. And then the others are severe anemia, heart failure. Absent bowel sound suggests that the potassium levels of the baby are low. And then if there is any form of gastric dilatation or obstruction, then you might even hear an intestinal splash. Next slide, please. Okay, refer to the nearest hospital if needed, call, text, etc., and prepare for the transport. These babies are very sick and need to be treated immediately. Remember to document what you have done with a two-way, possibly up referral and down referral form, and communicate personally with the inpatient facility while making arrangements for the safe and warm transport. Next slide, please. Okay, this is the form. We won't go into this. It's a dual form. We just always want to remind you of the next slide, reductive adaptation. A lot of times, what we get are reports of babies who are detected to have SAM, assessed to need transport to a facility, but in the process, they die, okay? When in the history, the baby was actually, yes, acutely malnourished for several days or weeks, but then suddenly when they're on their way to the hospital, they die. Why does this happen? Malnourished children have adapted to the low food intake by what is called the physiology of reductive adaptation. What does this mean? Because they have a very low food intake, rather than absorb all the energy and nutrients, they try to use these more efficiently by down-regulating their absorption, down-regulating their neurohormonal axes so that they consume less nutrients and less energy to be able to sustain basic organ systems, okay? That reduced activity of their neurohormonal axis and utilization of these nutrients affects all organs and cells in the baby's acutely malnourished body, and it causes very profound effects on the baby's body function, okay? Children with malnutrition do not manifest the usual signs and symptoms, and thus we can be mistaken, and the usual life-saving actions, for example, hydrating them quickly, giving them boluses of IV fluids, may be dangerous in the malnourished child. Let's talk about that a little more, okay? So next slide, please. Okay. All right. During this adaptation, so-called reductive adaptation, acute malnutrition involves internal processes, bodily processes that lead to an altered metabolism, like I described. And this involves disruption of all the organ systems, whether the heart and the blood vessels, the stomach and the intestines, the liver, the pancreas, the renal system, kidneys, bladder, immune system, every cell or antibody that is produced to fight infection, neurohormonal, the endocrine system, and the circulatory system. All these symptoms are affected and down-regulated. Next slide, please. Okay, muscles are affected. They become thin and weak, slow to contract. Intestines are affected by atrophy, a thinning of their lining, reduction in the enzymes that absorb carbohydrates, the substrates for energy, okay? Heart function, heart fibers are muscle fibers, and thus they reduce cardiac output to be able to minimize expenditures, okay? Loading them up with fluids can tend to precipitate congestive heart failure and fluid overload, okay? Kidneys have also been downregulated so that there is reduced kidney blood flow. For the doctors here, glomerular filtration rate is reduced, and even the sodium, the excretion, the wasting of sodium is impaired. No? So their sodium concentration may increase to very dangerous levels. Next slide, please. Other organ systems, we have reduced antibody-mediated, humoral, and cell-mediated immunity are diminished. No? 95, a large proportion of babies with SAM have systemic infection, but you might not detect it with the blood count, okay? Because of the altered immune systems. Temperature regulation there's failure of it. They don't sweat accordingly, and their body temperature may rise steadily. Okay, next slide, please. Okay, reductive adaptation and treatment means that we also have to understand how these body systems have learned to function at this reduced level. And we must not be trigger happy with flooding them with intravenous fluids just because they show signs suggestive of dehydration. Feeding, when it has been established, must be slowly and cautiously increased, because you can dump them and they will just develop osmotic diarrhea, for example, because their enzyme systems have been so downregulated and so unused to having nutrients in the intestinal lumen. Next slide, please. Okay, so this is a little bit of a discussion on why there is so much electrolyte imbalance in these babies with severe acute malnutrition. Normally, we all have what's called a sodium-potassium pump, okay, that is critical for the correct distribution of water in and around the cells and in our blood. Normally, you can see here in this diagram that potassium goes from the outside within the blood into the cell, and via also active transport. Both of these pumps function via active transport, consuming energy. And for the sodium pump, the direction is from inside the cell to the outside. What happens in reductive adaptation? These sodium-potassium pumps malfunction, and instead of the sodium moving out to the bloodstream, sodium goes inside, and potassium, instead of going inside the cell, exits the cell. Okay, so in effect, the electrolyte imbalance is very concerning in patients with severe acute malnutrition, especially also because of the fluid accumulation that occurs outside of the cell because of the failure of this regulatory mechanisms of the sodium-potassium pump. And this really confuses us when we have babies who are edematous, who are puffy from water, but actually are severely deranged in their intravascular volume. Next slide, please. All right. As such, because of the sodium imbalance, especially, we do not use our normal saline that we usually use for dehydrated babies or children without severe acute malnutrition. So there are special commodities for the rehydration of infants or children with SAM. Okay, and with dehydration or persistent diarrhea, there's also the need to replace potassium, but to limit the sodium. So you cannot use just the regular IV fluids that we normally use in patients without sodium, potassium derangements, okay? Next slide, please. So Resomal is a special rehydration salt for severe acute malnutrition patients. What do you do for non-emergency cases? For new patients with SAM, of course, we follow the integrated management of childhood illnesses medical check. I hope that many of you have undergone orientations to the IMCI program, okay? Having to do the medical history and what we talked about yesterday, the appetite test, anthropometric measurements, etc., etc. If there are no medical complications, then we can refer the patient to an outpatient therapeutic center, okay? I see chat questions coming in, but allow us to just go through the lecture and discuss later what if these commodities are not available, okay? So some patients already on treatment and transferred, it's very, very important always to maintain good records, okay? There will be unique identification numbers when these babies are registered, so that even if their family migrates, if they move between ITC, OTC, that they're always followed or tracked using this unique identification number. Next slide, please. Okay, I won't go through this anymore. Basically, your history, physical examination, very, very, very important is the dietary history. Next slide, please. Okay, here is where many of us get confused, okay? We said that because of severe acute malnutrition and reductive adaptation, okay, babies can be skin and bones, okay, and suggest that these babies are dehydrated. Why? Because they have sunken eyeballs, they have decreased skin turgor, but this is happening part and parcel of the acute malnutrition, okay? Skin and bones, bad skin turgor, sunken eyeballs, etc. If this is misinterpreted, what do we mean by that? In the absence of a history of intractable vomiting or diarrhea, of a history of inadequate intake, in the absence of a poor urine output and or a high heart rate, in the absence of all these other signs and symptoms and the history, the nutritional history that suggests dehydration, it can be very dangerous to assess these babies with these physical examination findings as dehydrated and to bolus them with fluids. Because if you bolus them with fluids and your heart muscles, your cardiac muscle fibers cannot compensate, then slowly, even in the course of the first few days after the ambulance ride with the fluid bolus on board, then these patients go into decompensation and die from cardiogenic failure. Next slide, please, or decompensation. So it's very, very important, again, to document everything, okay? So I'm going to start here, I'll stop here and transfer back to Dr. Donna. Doc Donna.
Hi, I'm back.
All yours.
All right. Thank you, Dr. Mian, for such a comprehensive lecture, when it comes to what to do when you get a child in your clinic and presents to you with potentially acute issues surrounding medical complications, together with acute malnutrition and with or without the cleft lip and palate. So thank you for that. Next slide, please. All right, so this is just pretty much a screenshot again of that patient flow pathway that Dr. Mian had already extensively discussed with everybody. Rest assured that these lectures, these webinars, the links to it will be sent to participants after the conclusion of these webinars. Next slide, please. Okay, so I think, it's just about time for an exercise. And as with yesterday with Dr. Drew, we will enable the polling function. So we enjoin you to please participate. So this exercise is then to refer to OTC or not. So this will actually test your stored knowledge at this point with regards to this question. So next slide, please. All right, so first line there, you can see we have Anna. She's our first patient, 50-month-old. An appetite test was done, and she does have appetite. She has no bilateral pitting edema. The MUAC is 10.2 or 102 millimeters, and the Z-score is less than -3 standard deviation. So can we please launch the poll? Would you refer this patient to OTC, yes or no? Can we have your answers, please? All right, so we will count down for maybe 10 seconds, and then we will end this poll. So 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Okay, can you end the poll, please, and share our results? So an overwhelming number of you, the majority, 85%, said yes, that you would refer Anna to the OTC. So Alex, can you please click on that link or click on the slide? So yes, we would refer to OTC by virtue of the fact that she has appetite, and then her indicators in as far as anthropometry is concerned are all above board. Okay, next slide, please. We have Buboy, who is 45 months of age, does have appetite, does have bilateral pitting edema, and then the MUAC is 111 millimeters or 11.1, and the weight for height Z-score is less than -3. So would you refer Buboy to the OTC? Again, we've launched the poll. This is yes or no. So we have 199 participants here with us, and we would count down again. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Okay, can we end the poll? All right, so interesting, because now 68% said yes, and then 32% said no. All right, Alex, could you please click on the slide? So the answer would be yes. There may be some confusion. We're talking about children who would be diagnosed with SAM, like Anna in the first go has SAM, and also Buboy has SAM. It's only a +1 bipedal edema, not anasarcus at all, like a grade 3 or even a grade 2. So in this case, these are children with SAM. And so the question is, do you refer them to OTC or not? And in both cases for Anna and Buboy, they both do have the appetite. So if you recall from the lecture yesterday with Dr. Drew, one way to determine whether a child goes to OTC or ITC is via an appetite test. So if there is appetite, then this child is a candidate for OTC, barring any other medical complications. All right, so we have the next child for us. Her name is Carmela. She is 7 months old. She does have appetite. She doesn't have bilateral pitting edema. Her MUAC is 11.7, and her weight for height, Z-score, is greater than -3, but less than -2. So could we please launch the poll for this one for Carmela? And everybody, please join in our poll. Okay, I will count it down. So 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. So end the poll, please. So again, I think we still have to get our concepts clearer. For Carmela, about half, no, or more, less than half said that 49% said that they would send Carmela to OTC, and 51% said that they will send Carmela elsewhere. So they said no. Okay, so click the slide, please. So in Carmela's case, the answer is no, because Carmela's anthropometry, the MUAC, the weight for height Z-score, all indicate the presence of MAM, or of moderate acute malnutrition. So Carmela won't go to OTC. Remember earlier, and I think we also mentioned this yesterday, that for MAM, they would be typically referred to targeted feeding supplementary programs. Okay, so Carmela has MAM. Carmela does not have SAM. Okay, so for our next patient, who is Daniel, Daniel is 12 months old, does have appetite, doesn't have bilateral pitting edema, and the weight for height Z-score is greater than -3 standard deviations, but less than -2 standard deviations. So can we please launch the poll? All right, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Can we end the poll, please? So 53% of you said that yes, you will send Daniel to the OTC, and 47% of the respondents, 72 of you, said no, that you will not send Daniel to OTC. So if you could please click on the slide, Alex. Will we refer Daniel? Yes, we will. Yes. Basically, because for Daniel's case, you have a patient with SAM. So the MUAC is 95, though the weight for height Z-score seems to indicate moderate acute malnutrition, but still the presence of an anthropometric finding that is supporting the diagnosis of SAM will then prompt us to send Daniel over, refer Daniel over to the OTC, given also that he has appetite. Okay, so for our last patient, that is Edel. Edel is 18 months old, has no appetite, has no bilateral pitting edema. The MUAC is 104 millimeters or 10.4 centimeters, and the weight for height Z-score is less than -3 standard deviations. So launch the poll. Thank you. All right. So what will we do with Edel? Where will we send Edel? Do we refer to OTC? So let's count it down. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Okay, end the poll, please. So, well, still the majority of you, 55%, said that yes, you will refer EDL to OTC. And then 45% of those who responded, a total of 76 responded, and 45% said no, that you will not send EDL to OTC. So let's look at the answer. Alex, if you could please click on the slide. It's actually no, we won't refer EDL to OTC. The mere fact that EDL has lack of appetite. Remember that part of our decision making with regards to referring either to OTC or ITC, one of the indicators is appetite. So in the case of EDL definitely has SAM based on anthropometry, and the fact that she did not pass her appetite test then prompts us not to refer to OTC, but rather to refer EDL to ITC. So I hope that was a good exercise, and that we will, there's still a lot more time really for us to get used to these decision making. Okay, so next slide, please. So just to remember that children with SAM cannot be treated like other sick children, as emphasized by Dr. Amian earlier about reductive adaptation, as this alters the child with SAM's physiology. And therefore, we cannot go by what we call in Filipino dekahon, or routine treatment, because this may spell into more harm than good for the patient. And so we need to specially treat these children, and there's actually a specifically developed therapeutic food such as RUTF. And I know there have been questions about RUTF yesterday, so move on to the next slide. So what exactly is ready-to-use therapeutic food? It is energy dense, it is vitamin enriched, and nutritionally equivalent to another therapeutic milk, which is F100. It is recommended for use in the treatment of acute malnutrition, severe acute malnutrition in children at the age of 6 months and above. So this actually can meet the particular technical and quality specifications in as far as its composition for children with acute malnutrition. Okay, so there are many questions that are associated then with RUTF, and I know we can't really fully answer those questions, but let's try and maybe further as we go into our open forum at the end of the lectures. So next slide, please. So the usual questions that we get about RUTF, who are supposed to oversee treatment with RUTF? So those who have been trained in PMAM, and basically pretty much DOH has been very good with the scale up of the training for PMAM, and we will see the maps later on, a few slides down, in as far as the reach of the training or the coverage of training for PMAM is concerned. And definitely overseeing treatment is not only limited to physicians, could also be due to the trained nurses, midwives, and could also be followed up by barangay nutrition scholars and barangay health workers. Is RUTF available over the counter? No. Where could we then access RUTF? In this whole scheme now, pushing into universal health care, we know that the push is to establish networks of healthcare providers, and therefore it would be good to coordinate and refer to health facilities and staff that have been trained in PMAM. And as I said, we will showcase those facilities where they are and the numbers of trained facilities a few slides down. So are there alternatives to RUTF? RUTF per se, there is no locally produced equivalent alternative. However, there have been a number of recipes that have been formulated by different facilities. And I know for those who have trained in PMAM here, the most popular one comes from PGH, from the Philippine General Hospital. But then again, as I said, we can discuss more at the end of all these lectures. Next slide, please. All right, so we got the data from the Division of the Family Health Office. Now it's Child Health Development under the DOH, in as far as the number of OTCs that have been trained across the country. And this is their data up to the year 2018. And it showcases that 564 OTCs have been trained already, by virtue of the rollout with the Department of Health. And as you can see, practically all the regions have been covered. Though we did miss out seeing facilities for Region 4A and Region 6, in as far as OTCs are concerned. So next slide, please. Then we have ITCs, or the Inpatient Therapeutic Care Facilities across the country, and this is DOH data as of 2019. There have been 178 ITC facilities that have been trained. And in as far as ITCs are concerned, all the regions are covered. So this is great. I think the question now is how well functioning these facilities are, particularly in the context of the pandemic, where, as we know, all the supply cycles and processes may have also been deterred because of the pandemic, and also the reprioritization of resources, of scant resources. So next slide, please. All right, so pretty much what this entire hour or so has been is about screening, triage, and referral of acute malnutrition. And this starts, as we've emphasized, in enjoining our community partners to help us with this, whether it be in the screening of acute malnutrition, or in this case of cleft lip and palate. And as also highlighted by Ma'am Mian or Dr. Mian earlier, it could be that we pick up on acute malnutrition, and this child may then coincidentally have another pathology, such as a cleft palate, for example, that may have been missed. Okay, next slide, please. Okay, so again, as I said, we keep on flashing these slides for you for recall, and I hope you get used to them and learn the color-coded numbers or references. So green is normal, yellow is ma'am, red is Sam. So this applies for children between 6 to 59 months, and we do use the MUAC on them as standard right now. Next slide, please. And this is for infants younger than 6 months. And the only difference being is that right now, MUAC is still something that's being studied in as far as use in anthropometry for the diagnosis of acute malnutrition in this age group. And we will hear more of that later from Drs. Drew and Mian. Next slide, please. All right, so once we do have a child screened and assessed and identified to have moderate acute malnutrition, as we have said yesterday and early on a few slides back, is to refer this child to targeted supplementary feeding programs. Next slide, please. So just to highlight the difference, there is blanket supplementary feeding program, and there's targeted. So for blanket supplementary feeding program, this may be the case of like having an acute emergency humanitarian situation. So all the children or all those who are vulnerable will get the supplementary program, just so to avert new incidents of acute malnutrition. Whereas in targeted supplementary feeding programs, children who have been already identified as having moderate acute malnutrition will then receive this particular ration. Okay, next slide, please. Okay, so we go to an exercise whether now to refer to targeted supplementary feeding programs or not. So I hope you're ready again to join us in our polls. Okay, so for our first patient, this would be Anna again, and the age is 50 months, and then there is no bilateral edema. Her MUAC is 10.2 centimeters, and her weight for height Z-score is less than -3 SD, or standard deviation. Sir Alvin, could you please launch the poll? All right, so would you then refer Anna to a targeted feeding supplementary program? All right, so there are 198 participants right here now, and we're seeing people dialing in and punching in their answers, whether yes or no. All right, so I'll count it down. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. End the poll, please. And 53% of you said that yes, you will refer Anna to the targeted feeding supplementary program. And 47% of you said no. Okay, so let's see what the answer is. Alex, if you please could show. So no, we won't refer Anna to the targeted supplementary feeding program because Anna has SAM. Anna has severe acute malnutrition. And this is based on her MUAC and on her weight for height Z-score. Okay, so when a patient has SAM, this patient will either go to OTC or to ITC depending on what the appetite test result would be, or the presence of other medical complications. Okay, I hope that's clearer now. So now we have Buboy, who is 45 months old, does have bilateral edema. The MUAC is 11.1 centimeters, and the weight for height Z-score is -3 standard deviations. So please launch the poll. Would you refer Buboy to the targeted feeding supplementary program? So again, we have 198 participants here. And we can see people are still punching in, no? Dialing in their answers. Either yes, you would refer, or no, you wouldn't refer to targeted feeding supplementary program. So I'll count it down. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. And poll, please. So 31% of the 72 respondents said that yes, they would refer to TFSP, and the majority, 69%, said no, they wouldn't refer Buboy to TFSP. So Alex, can you please reveal our answer? So again, no, we wouldn't refer Buboy to TFSP. And the reason for this is because Buboy has SAM again, no? Buboy has bilateral edema. Buboy's MUAC also falls under, no? And then as well as the weight for height Z-score. So we wouldn't refer Buboy to targeted supplementary feeding program. Rather, Buboy would then go to either OTC or ITC, depending on what the appetite test result would be. Okay, so for our next patient, it's again Carmela, who is 7 months, has no bilateral edema. Carmela's MUAC is 11.7 centimeters, and her weight for height Z-score falls between -3 standard deviations to less than -2 standard deviations. So launch the poll, please. So will you send Carmela to the targeted feeding supplementary program? Those we send to TFSP are those who have MAM. Okay, for SAM, it's either they go to OTC or ITC, depending on the presence of medical complications or what the results of the appetite test is. Okay, so let's count it down, no? So 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Can we end the poll, please? All right, so majority of you, 82% of those 73 who answered said yes, that you would refer to the FSP, and 18% said no. Okay, so Alex, could you reveal our answer, please? Right, so In the case of Carmela, yes, we would refer her to TFSP because she has MAP, no, by the anthropometric measures, okay, and she doesn't have edema. All right, so Daniel, our next patient, is 12 months old, has no bilateral edema. The MUAC is 9.5. The weight for height Z-score is -3 standard deviations to less than -2 standard deviations. So the poll is launched, so please dial in your answers. Would you refer Daniel to TFSP? So the thinking process should be first, does he have SAP or does he have MAP? And then that will help you discern whether he should go to the route of intervention for SAM, which is OTC or ITC, or should he go to the MAM treatment, which is TFSP? Okay, so let's count it down, no? 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. End the poll, please. So 44% of you said yes, that you will send Daniel to TFSP, and over a little of the majority, 56% no, said no, that you will not send them to TFSP. So Alex, could you please reveal our answer? So the answer is no. We wouldn't send Daniel to TFSP because Daniel has SAM. If you just look at the MUAC here, it's 9.5, even in the absence of the edema. And even if the weight for height Z-score is -3 to less than -2 standard deviation. As again, as I mentioned earlier, if you have that one indicator or one anthropometric finding that will be supportive of the finding of severe acute malnutrition, then we will then diagnose accordingly and send and refer the patient to where it would be appropriate. In this case, it's either OTC or ITC, depending on resulting appetite test. And then our last patient is Edel, who is 18 months old with no bilateral edema. The MUAC is 12 centimeters. The weight for height Z-score is -3 standard deviation to less than -2 standard deviation. So launch the poll, please. Can we please enjoin you to answer and tell us where you would refer, whether you would refer Edel to TFSP or not, okay? So I think we're being pressed for time, so I'll count it down. 5, 4, 3, 2, 1. Okay, can we stop the poll? And 72% of those who answered, usually we get 72 people who dial in answers. So 72% of those who responded said yes, they will send Edel to TFSP. And then 28% said no. So Alex, could you please show us the answer? So yes, we will send Edel to TSFP because Edel has MAM, no? Based on MUAC and the weight per height Z-score. Okay, next slide, please. I hope that was enlightening again for you. So of course, when we do screening, we will get patients who are neither SAM nor MAM. We will still send these patients as appropriate and if available to blanket supplemental feeding program. Non-SAM, if they're MAM, then they go to targeted supplemental feeding programs. And of course, there's still the PEGs, no, in terms of healthcare services. We give them advice and counseling on proper IYCF practices, on breastfeeding, of course, on the importance of exclusive breastfeeding and continuing on even with complementary feeding at 6 months of age. And then for guidance in as far as when to again consult, particularly if you have a child who is sick. Okay, next slide, please. Okay, so in summary, for the past hour and a half, we were talking about awareness and engagement of both family and community about malnutrition, in that it will help with earlier screening, diagnosis, and management, which is what we want, so we have better outcomes. And then when appropriately screened, children with SAM can be safely treated in the community, and MAM as well. No? Children with malnutrition have reductive adaptation, which necessitates a specialized approach to management, and timely recognition of the indications for referral to ITC is potentially life-saving, as emphasized by Dr. Mia, especially in the presence of medical complications. And there are already existing OTC and ITC facilities in the country around the regions that we could network with. Okay, so I guess that ends my talk. We will take a 5-minute wellness break. I'm sure it's been quite a packed first lecture for you, and you may need your time just to chill and relax for the next 5 minutes. Thank you very much. So right now it is 3:35 on my end. So at 3:40, may we reconvene again, please, for our next lecture. And this is going to be really good because Dr. Mian and Dr. Drew will take us into a sort of a deep dive now, going into the management of acute malnutrition in infants, looking at those who are less than 6 months. Thank you very much.
From the time they are born, children with cleft lip and/or palate face many challenges. They struggle to eat, breathe, speak, and even survive. Treating cleft lip and palate requires a range of long-term, comprehensive cleft care interventions. But around the world, there is a severe shortage of medical professionals with the skills or resources necessary to provide this specialized care. This is why SmileTrain, as part of our sustainable partnership model, offers a variety of innovative training and educational resources to cleft care providers around the world. For over 21 years, we have partnered with cleft care professionals at more than 1,100 hospitals in over 90 countries, offering more than 40,000 training opportunities, a number that is growing every day. Over the coming years, SmileTrain will scale these programs and resources because we know that behind every smile, there's a team of healthcare professionals who made it happen.
Maraming challenges rin na pagdaanan ko. Nandiyan yung tinutoksokan, yung bata ka. Siyempre, ikaw, nasasaktan ka, di ba?
Hindi ko sila lang sinasabi kay mama, pero may times na binubuli pa rin ako. Halos araw-araw yun, pagpapasok ko sa school. Tapos, nasarin ka nila ng bingot, gano'n. Tapos, halimaw.
Mga classmate mo, ina-assure mo ako. Ina-assure mo minsan, ina-assure mo ako. Mananalahat mo ako, tinatawanan mo ako.
Nung baby na po ako po nilang parang i-opera po ako. Akala po nila parang, mamamatay na nun po.
In the Philippines, there are about 5,000 babies born with a cleft lip and/or palate annually. Cleft is far more than a cosmetic problem. Children with untreated clefts not only live in isolation, but also face physical difficulties with eating, breathing, and speaking. As a result, most of them don't attend school or ever hold a job. Cleft repair surgery is safe and the transformation is immediate. SmileTrain is the world's leading cleft charity that supports comprehensive cleft care, including surgery, orthodontics, dental services, speech therapy, nutrition, and psychosocial support. SmileTrain's sustainable model focuses on training local medical professionals in more than 90 countries to perform cleft repair surgery and comprehensive cleft care in their own communities. They then go on to train others, creating a long-term, sustainable system.
Kung hindi ako na-operahan, siguro baka wala ako dito ngayon. Baka nasa bahay lang ako, nagtatago.
Magiging normal na rin yung buhay ko, yung wala nang manlalait sa akin.
Masaya po, maayos-ayos po yung mukha ko po, hindi po kanaya po dati.
Ngayon po, nakakangiti na po ako. Natutunan po ng SmileTrain.
Cleft repair surgery may take as short as 45 minutes, but the impact is life-changing. Former patients have the opportunity to attend school, get a job, start a family, and contribute to the society at large. Refer someone in need today and give the gift of a smile and a second chance at life.
All right, so I think that's about the 5 minutes of our wellness break. I hope our participants are actually coming back in. I see Ms. Madrinian Garcia raising her hand. As I said, we will keep all our questions to the very end of all our lectures, wherein we will still have an open forum. If you like, you can utilize our Q&A box so that you can put in your thoughts already and your questions on there and have them ready for our open forum discussion. All right, so I did tell you that our next lecture is really going to be something to look forward to. It is going to be tandem delivered by our two heavyweights, as we call it, Filipino, our bigatens. And these are no less than Dr. Andrew Buku and, of course, Dr. Mian Silvestre. And the topic on hand will be about the management of acute malnutrition in infants who are less than 6 months. No? So again, a lot of development happening here, a lot of research still ongoing when it comes to what to do for these babies who are less than 6 months old. And as we saw from the lectures yesterday, these would be the subset of populations that are really direly getting affected, no, when it comes to issues of undernutrition. Okay, so take it away. So I believe Dr. Drew Buku will have the floor first.
Thank you very much, Dr. Donna. So good morning, good afternoon, and good evening, everybody, once again. And we thank everybody. It's still a very overwhelming number of people in this webinar right now. So we're very thankful for this global platform that we have in order to share this this lecture on malnutrition. So the lecture from Dr. Mian and Dr. Donna is a tough act to follow, but we'll try our best. Just to bridge over from that particular lecture, and also from yesterday, actually. So we've been talking about from yesterday, we had a very quick overview about malnutrition in terms of the background and the context, and also over the CMAM program and how it's been implemented globally and also in the Philippines. And we also went into the process of trying to start to identify who might be in need of treatment. And we underscored the importance of getting the right measurements and being able to take everything together in order for us to be able to identify who are the ones who are malnourished and who might be needing treatment. And just now we also went into the triage and the treatment and referral for these children who have been identified with malnutrition. But in the Philippine context, the guidelines are quite clear to say that the guidelines are applicable to children who are 6 months of age to 59 months of age, so roughly from 6 months of age until 5 years of age. So of course that already I'm sure that a lot of people already have questions like, what do you do for children who are not in that particular age group? And in particular in the Philippines, we've been having a lot of questions for what do you do for the age group that is less than 6 months, especially in the context of data that was introduced yesterday. So this lecture is actually quite new in contrast to the other lectures that we have had before, but we'll be going now into the management into acute malnutrition in infants under 6 months of age. So next slide, please. So at the end of this session, the learner will be able to define management of acute malnutrition for small and at-risk infants under 6 months and their mothers, to identify criteria for at-risk mother-infant dyads, and thirdly, to identify linkages and referral of small and at-risk infants under 6 months and their mothers. So as you can see, there's already some terminologies being introduced and the objectives. We'll go into that as we go along in this lecture. So next slide, please. We flashed this particular slide earlier. It's basically an overview of the different components of community-based management of acute malnutrition. So as we can see, there are different components are identified up by the different circles. Severe acute malnutrition for inpatient care and outpatient care each have their own circles in pink and red. On my screen, Moderate acute malnutrition is there in a yellow or oranges circle. And as we can see here, the community mobilization and the outreach is encompasses everything, because we just want to, of course, highlight the importance of having the community there in order to make all of these components happen. But as we've been discussing over the past couple of over the past couple of lectures, it's not very it is not clear about what to do with children who are less than 6 months of age. And basically, it begs the question, where does MAMI, or previously as it was known, management of acute malnutrition in infants, where does that fit into the picture? So this is especially important in context with data that was raised yesterday. Next slide, please. This is a graph that was shown yesterday. It's basic. Just to recap, it's a description. It's a depiction of the rates of wasting in children under 5 across the different years in the Philippines. So as you can see, for each year there are six bar graphs, and these represent the different age group, the different sub age groups within the under 5 years of age. So as you can see across the years, just to recap also, the blue line, the dotted blue line, represents the the global acute malnutrition rate in the Philippines. So as we can see here, across the different age groups, the ones that are most affected, it's actually quite consistent that across the years, the age group of 0 to 5 months, or basically under 6 months, is regularly ranking quite high among the first or the second of the, basically in terms of the prevalence of acute malnutrition. So that's from 2008 2019. Overall, there's been a decrease. As we can see, in the global acute malnutrition. But of course, we're not so. We still have to see the effect of the pandemic as well in terms of the impact on malnutrition. But as we can see here, it's definitely highlighted that even though we have a program right now that is specifically addressing the nutrition needs of children 6 to 59 months, there's a big gap that we still need to address, especially for children who are under 6 months of age. So next slide, please. So we'll now go into some stories that we've encountered actually. So as we were saying, we've actually done training specifically focusing on the age group of 6 to 59 months of age. But then it begs the question, of course, that when we do screening, it's inevitable that other cases who are outside of this age group comes up. So in this particular case, actually, so this is a picture of a child who was identified when there was active screening conducted in a municipality in the southern Philippines. And because there, as Dr. Donna already mentioned, since training was already being undertaken, there was a heightened awareness already in terms of on the problem of malnutrition. So during active screening, this child was picked up, was identified through active screening by a barangay nutrition scholar or a community nutrition scholar and social worker, and this was referred subsequently to the municipal nutrition action officer, who was able to confirm that the child did indeed have severe acute malnutrition. What was interesting about this case is that this particular infant was actually located in an area that this infant was identified in an area where she was not originally living in. It was just actually just picked up. He was identified in one particular municipality, and it was referred to the municipality where this infant was actually residing in order to avail of actual treatment. But again, it was a big question, because after getting all of the information of the patient, it was found out that the patient was under 6 months of age, and the guidelines that we have right now does not cover that particular age group. So of course, the community health workers had questions about how to proceed with the treatment. So once again, we would just like to give photo credits to the rural health unit and the birthing clinic of Datu Saudi Ampatuan in Maguindanao for sharing this particular picture with us. Next slide, please. We also have another case here of pretty much the same situation, but this particular child lives in Basilan, which is actually one of the far-flung areas in the Philippines. It's quite far from basically what we want to underscore here is that they have limited access to health and nutrition services. So this particular child was identified in that particular in that far-flung area, but then treatment was not really readily accessible. So even there, the people who were charged with the treatment of this individual, especially here in this case, we'd like to mention the nutritionist dietitian of the Bangsamoro Autonomous Region of Muslim Mindanao, Celia Sagaral. Basically, it was not a straightforward problem in how to deal with the management, how to properly manage this child who was under 6 months and yet had the problem of severe acute malnutrition. So next slide, please. And in the trainings that we've had before, it was already the concept of MAMI was already being flagged about. But MAMI originally stood for Management of Acute Malnutrition in Infants Under 6 months. Over the years, the different technical experts have been doing several back and forth consultations across different areas who have been conducting community-based management of acute malnutrition programs, specifically because it's been an identified gap. We have done a lot of milestones in terms of treating the 6 to 59 months of age group. But what about the other age groups, specifically for those under 6 months? So over the years, the acronym of MAMI is actually evolved now, as we can see here on the right side of the screen. It is not an accurate translation of the acronym, but this actually is a more comprehensive treatment, an approach or a perspective on what needs to be done for management of children under 6 months. Because now MAMI stands for the management of small and nutritionally at-risk infants under 6 months and their mothers. So there's a specific emphasis there that needs to be placed, which we will be discussing more in the next slides. So let's proceed with our next slide. We want to highlight here, and it's been raised since yesterday, that we cannot emphasize enough the importance of the first 1,000 days of the life of a child. And as we've already mentioned, it starts even just from conception until childbirth, the 270 days. And then there's a very specially identified period from birth to 6 months of age, the next 180 days of life. It is very important to identify this because, as we know, we have to emphasize that breastfeeding is very important in order for us to ensure the optimum nutrition of our children. And just as our other nutrition programs, good nutrition, health, and proper care in the first 1,000 days give the best start to life forever. And basically, the MAMI program is also one of the things that we want to be able to implement in order to help ensure this goal. Next slide, please. So this brings us to the development of the MAMI Care Pathway Package. So as we were mentioning, over the past couple of years, the CMAM guidelines are dynamic, basically. It's evidence-based, and it relies on a lot of feedback on the areas where CMAM is being implemented. Just to highlight again, CMAM is the global term for it, but in the Philippines, we call it Philippine Integrated Management of Acute Malnutrition, or PMAM. So in your particular country, it might the term for it might be different, but for the sake of a universal name for it, we call it community-based management of acute malnutrition. And basically, what the technical experts have been doing is that now they've specifically developed guidelines to treat the age group of 0 to 6 months of age through the MAMI Care Pathway Package. The next slide, please. So the guiding principles behind the pathway is that we consider we don't just look at the infant alone, but we consider the mother infants together as dyads. So we treat both the nutritional status of not just the baby, but also the mother. And the MAMI pathway helps put the previous guidelines, the WHO 2013 guidelines, into practice. And it emphasizes that it's an integrated care pathway approach. Next slide, please. We would just want to highlight that MAMI is one of the techniques that we are implementing in order to address the critical care gap. And we've noticed actually that in terms of the mother and baby dyad, they usually have no access to support immediately after birth. but upon discharge, they usually have access to support immediately after birth. But upon discharge, there is little to no support available. And sometimes that is why we definitely recommend regular postnatal care visits, because sometimes as early as 2 to 3 days after birth, or even until 7 to 14 days already, there are certain if visits do not happen during that particular time, these are missed opportunities for us to ensure the optimum nutrition of our children. So it needs to be ensured that our regular programs are able to incorporate these particular guidelines in order for us to maximize the different opportunities and not to miss out on the treatment of our children. Because commonly, mothers and newborns sometimes are not together at their visits, or that breastfeeding episodes are not observed. And we want to emphasize that many of these cases can be treated on an outpatient basis. We don't need to admit children and their mothers to hospitals or facilities, especially now in our setting where there is a pandemic still going on. We want to maximize our opportunities that we have for outpatient care. And just to highlight, of course, that sometimes one of the unfortunate outcomes is that children, and in this case, sometimes cleft infants, are left waiting, and sometimes without counseling until they reach the appropriate age group. So sometimes because the mothers and their children, when they seek consult, the healthcare worker is not oriented on mommy specifically, they would advise that you have to wait until 6 to 59 months of age, which of course we know that should not be the case, because regardless of the age, we should not be turning these children away. We should be able to identify the problems that they have, and in order for us to be able to refer them to the proper facilities where they can avail of treatment. The next slide, please. And we want to emphasize here that the overall goal of the Mommy Care Pathway Package is that every small and nutritionally at-risk infant under 6 months and their mother is supported to survive and thrive. And we do this by screening all the dyads to identify those who are small and nutritionally at risk, to assess and diagnose common feeding, health, and social issues in dyads that may contribute to or cause the nutritional risk, and to manage and treat these common problems and support mother-infant dyads. So as you can see in this particular screen, and we will be going through this throughout the lecture, yeah, we screen, we assess, and we manage and treat the mother and infant dyad. Next slide, please. And who is our target population? We are targeting specifically the small and nutritionally at-risk infants, and of course their mothers. So we're going into further detail. This includes infants who are born with low birth weight, so those born less than 2,500 grams. These includes the premature or small for gestational age children. We also include here those who are born with clinical or congenital anomalies, and also those with who may have multiple birth. Yesterday, it was also identified that suboptimal breastfeeding is actually a form of malnutrition. So if this is happening in the mother-infant dyad, they are considered nutritionally at risk as well. Next slide, please. So fourth, we also target actually the next 4 criteria is a throwback also to the lecture yesterday, because these are highly dependent on us being able to do proper anthropometric measurements. So if we can see that the weight of the child is faltering, meaning that it is not increasing in weight or dropping down, or if we see that the child has low weight for age or low weight for height, less than -3 disease scores, then definitely these children are considered nutritionally at risk and should be referred to the program. I just want to highlight in number 7 that low MUAC is also being considered as a criteria. Yesterday, we were emphasizing that for children under 6 months of age, we don't routinely take the MUAC. But as we were mentioning, the guidelines are dynamic. Presently, that is still the case. It's not fully recommended, but some studies are showing that there might be some use to it. So there might be some use to using the MUAC for children under 6 months, but using a different cutoff value. So just for our information, the guidelines are dynamic and they might change, but rest assured that any changes are evidence-based and and of course will be everybody who is involved in the treatment should be aware of any possible changes in the guidelines. So next slide, please. So the desired outcomes of the program, we want to reduce the risk of mortality, but aside from that, we also want to reduce the risk of illness and poor health and the overall risk of malnutrition. And on the flip side, of course, we want to improve the overall growth and development and the long-term health of our children under 6 months and their mothers. Next slide, please. So MAMI interventions, we want to emphasize that the integrated care pathway uses existing health system contact points to identify and enroll infants under 6 months of age. So as we can see here, it works with and strengthens existing health and nutrition services. It bridges interventions across relevant disciplines, and it connects infant and mother diets to relevant services through referral pathways. As we will be seeing later on, the MAMI guidelines are actually not something new. They are actually, the guidelines are there to enable or make it possible or to synergize with what is already existing in a particular area, because a lot of the services that are needed to treat children who are malnourished are already there, and it is a matter of being able to maximize and make use of the existing resources. And also, of course, if we don't have those resources, we'll be able to identify and prioritize what areas need to be strengthened. But I'm sure actually as we go through the lecture, a lot of these areas may actually already be existent in your particular area. So it's a matter of taking advantage of what is there in your particular area in order to be able to go forward and establish your own MAMI program. So as emphasized here, implementation is highly dependent on the local context or the settings in terms of human resources, existing services, supplies, etc., etc. So next slide, please. So we go for a quick break here in terms of a check for the participants regarding their understanding of the concept. So we have a multiple choice question on the screen, and we will be doing a poll again. So we invite everybody to please consider the question: which of the following statements are true about the MAMI Care Pathway Package? So is it A, it considers infants and their mothers as dyads; B, it covers a crucial gap in care for infants from birth until 6 months of life; C, it specifically targets small and nutritionally at-risk infants, including those with clefts; and D, all of the above. So among those choices, kindly, thank you very much, Sir Alvin, for bringing up the poll. Kindly indicate your answer, and we will be awaiting for your answers. We will give a few more seconds for everybody to click in their answers. Please don't forget to press the submit button in order for your answer to be recorded. So we will be ending the poll in 5, 4, 3, 2, 1. So Sir Alvin, can you show us the results of the poll? And as we can see here, majority of our participants, 86% of our participants answered all of the above. And as we can see, if you can click, Alex, if you can click on the slide. Oh, okay, sorry about that. Can we go back? Sorry, I thought that the answer would be showing on the screen. But the answer for the question is D, all of the above. All of these answers are very essential for the management of acute malnutrition. We treat the infant and the mother as a dyad. The MAMI program specifically covers a crucial gap in terms of care for the dyad, and it specifically targets small and nutritionally at-risk infants, including those with clefts or other factors that may put them at risk. So at this point, I would like to tag in Dr. Mian again to go through the next parts of our lecture, where we will now be going through the different parts necessary for identifying and also treating children who less than 6 months who may be malnourished. So Dr. Mian, back over to you.
Salamat ng marami, Doc Drew, and thank you to the 203 participants who came back today and who stayed for these last 2 lectures. Doc Drew, thank you for presenting the framework of what we want to talk about, the so-called MAMI Care Pathway Package. And thank you to the participants for the majority answering correctly, no? Na like we've always been saying, we should be looking at the newborn and the infant not separately from his mother or her mother, but as a dyad, as a pair, as a unit, no, and not separately. And that there are crucial points of care that we somehow are not covering for these precious dyads. For babies with cleft, Some of them, we may know about these congenital defects already in the antenatal care period. And that is something that we should optimize, that something we should maximize or take the opportunity to give them early care. For many of them that are not missed, of course, you have the obvious deformity at birth. And therefore, for cleft patients, we have the open opportunities to be able to intervene with these mammy care interventions in that crucial first 6 months of life, okay? And going by IYCF, what is the optimal feeding for babies less than 6 months? It still is and will be exclusive breastfeeding starting in the first hour of life. Here in the Philippines, we call the practices together with the care for the mother, the first embrace or unang yakap, and exclusive breastfeeding continuing up to 6 months of life. So this is what we're going to talk about in the next 20 minutes or so, okay? I'm not going to go over this whole slide, this whole busy slide, but this is a bird's eye view of the mommy care pathway, the who, the what, and the where. So we're going to talk practical points. We're going to talk about screening. We're going to talk about assessment, support and management. And of course, at the end point, 6 months of life, we're going to talk about what to look for by way of outcomes. Next slide, please. Okay, so as I outlined from the diagram, these are the steps that we're going to talk about. Next slide, please. Okay, rapid screening, what does it entail? It entails checking, we said, of danger signs and using always our dictum, start with what you have. And what we have in many communities now is health workers trained in the integrated management of childhood illness. So we have to talk about IMCI danger signs. We check for infant growth. We check for feeding risks. For the cleft patients, these are obvious risks. Once properly identified, these are obvious, both feeding and breathing difficulties as early as birth, okay, or even in the antenatal period. And not a much ignored, much forgotten topic is the issue of maternal health and well-being, the mother being that other half of the dyad. Next slide, please. All right, so step one, rapid screening. What is the where and the who? It is at any contact point, whether in the community, whether on an outpatient basis, when a patient comes in for the postnatal care checkup at 2 to 3 days ideally, and then again at 7 to 14 days. It could be at the vaccination visits at 6 weeks, where let's say the baby was delivered at home and never seen within the health system until the 6-week immunization visit, okay? It could be in the hospital when a baby is admitted for pneumonia or aspiration or acute gastroenteritis, okay? What does it consist of? What does this rapid screening consist of? We talked about the IMCI-based triage, categorizing the urgency of medical complications and the actions that need to be taken to identify these life-threatening signs. If they do not present with any danger signs, we go over if they do not present with general danger signs, we still go over mammy-specific screening to assess the mammy-related risk factors, not just in the infant, but also in the infant's caregiver, primary caregiver, which is usually the mother, okay? Dyads with a mammy-related risk, okay, whether in the infant or the mother, are referred for a full mammy assessment at the nearest health facility. So this is where our guidelines from 2014 for PMAM or for SAM, okay, there was a crucial gap, no, in the less than 6-month-old. And of course, now we're highlighting the gaps for infants with clefts. Okay, next slide, please. Okay, this is another very, very busy slide. So what we're gonna do is zoom in on the red, the yellow, and the blue and green. Next slide, please. These are the signs of what are called very severe disease, severe mental health concerns in the mother, and the IMCI main symptoms for high-risk infants. So it's color-coded red to mean that if any of these signs in the infant or the mother are detected, then this needs to trigger urgent urgent referral to a hospital, okay, to a health facility, not just a health facility, but a hospital. But prior to that transport, the provision of pre-referral treatment, so-called stabilization, so that transport can be performed safely and with a warm chain of protection. Okay, so let's talk about those danger signs. We can go over this once, but not necessarily repeatedly later. But what are these danger signs? The inability to feed, okay? Convulsions, severe chest indrawing. We talked about use of accessory muscles. Fast breathing, okay? High or low temperature. Movement only when stimulated. We talked about non-spontaneous movements, right? Only if they move only when stimulated, when touched, when nudged, then that is a danger sign that the baby is not moving outside of these stimulations. And of course, a mammy-specific sign, which is bilateral edema, okay? Like we learned yesterday, grade 1, 2, or 3, if it reaches the face and the upper extremities, okay? For the mother, if the mother appears out of touch with reality, in other words, she is manifesting with psychotic, with breaks from reality, or at risk of harming herself, that is a danger sign that raises severe mental health concerns for the mother and requires urgent referral to a hospital, okay? So this red panel refers to emergency referral to a health facility, specifically a hospital, if there are signs suggestive of very severe disease of the infant and a severe mental health concern for the mother, and or high risk infant otherwise without those mammy-specific signs. Next slide, please. We go to the moderate risk, and I will not read these off anymore because we're going to eat too much time. But please always remember that you look at both the infant and the mother. The very common practice of sending the baby off with the grandmother or off with the husband to the health center for checkup, but without any information as to how the mother is doing at home, is a very common practice that needs to go away. If the mother and the baby cannot be seen together, then at least at the local government health unit, especially at the barangay level, then what's important is these babies are seen through home visits, okay? This is what we're trying to push for, especially now, even during the pandemic, that the disruption of essential services for postnatal diets and infant care are all irregular, okay? So these are the risks for moderate risk infants and mothers that require an enrollment in a mammy outpatient care facility. Okay, next slide, please. And of course, either potential or low risk is the absence of the danger signs or the signs of moderate risk. Always emphasizing that you not only look at the infant, but also the state of mental health of the mother. Okay, and we'll talk about how do you screen for mental health for the mother in a bit. Next slide, please. Okay, so we talked about rapid screening 1.1, and these are the danger signs. Again and again, we talk about either intractable vomiting, poor feeding, convulsions, difficult breathing, or fast breathing, temperature high or low, both are danger signs. And then lethargy or unconsciousness or lack of spontaneous activity. For mammy-specific danger signs, like we were pointing out yesterday with the edema test, then it requires that 3-second gentle pressure with the thumbs on both of the dorsum of both feet. Next slide, please. All right, ask. What are those risk factors that you can ask about? Let's say the mother is not there. Ask the family member, was the baby born too early? Was the baby too small, less than 2.5 kilos or less than 5.5 pounds? Is that equivalent? Or was there a recent weight loss or failure to gain adequate weight, including a neonate, a newborn less than 28 days of age, who has not gotten back his or her birth weight, okay? Anthropometric measurements as we review, weight for age Z and weight for length Z, and what is being explored now, the accuracy, validity of MUAC, our mid-upper arm circumference for less than 6-month-olds, okay? Next slide, please. Okay, now we go to those were the natal findings on history. Ask also over the last 2 weeks, 14 days. We asked the mother or the primary substitute caregiver, the surrogate caregiver, how often have you been bothered by the following problems? Little interest or pleasure in doing things, feeling down, depressed, or hopeless. And we will see later a detailed scoring of that of those mental health screens for the mother. Next slide, please. Okay, 1.3. It looks like they were interchanged a bit. We look at the infant feeding risk, and of course, for babies with obvious cleft lips, like this baby, and or less obvious cleft palates or even clefts of the submucosal palate. Does the infant have difficulty feeding? Not only that, it's best to observe for at least 4 minutes an actual feed. Back in the day when I used to practice pediatrics, I would ask the parents to not feed the baby so that when they do come to me, I can observe a hungry baby at the breast and not dismiss a baby without any observation of the breastfeeding. Does infant usually receive any other foods so that these are actually non-exclusive breastfeeding practices? Does the mother have feeding concerns or breast problems like we talked about in the first webinar, our second line breastfeeding counseling concerns? Next slide. Okay, step 2 now is what is called the MAMI assessment. And this is basically the IMCI-based triage to determine if any deterioration has occurred, which requires maybe more specialized or a higher level of expertise to identify other issues. Okay, so the dyads or the pairs are categorized as to low, moderate, and high risk, with a corresponding need for referral to either a routine, outpatient, or hospital care of the MAMI case. Next slide, please. All right, so again, we are repeating this so that you can actually memorize the danger signs that we keep talking about: feeding difficulty, convulsions, breathing difficulty, low or high blood pressure, movement, non-spontaneous movements, or the MAMI specific finding of bilateral edema, suggesting very severe disease and urgent or emergency referral. Next slide, please. Okay, for moderate risk or potential risk, again, the risk factor is there. Feeding difficulties, observe a breast feeding and inspect the breast. For male health workers, it's important that you have a female chaperone there so as not to stress the mother with your presence while breastfeeding. And of course, questions on screening on maternal health. Maternal MUAC is also being validated. The cutoff of 23 millimeters is what is in most guidelines at the moment. But here in the Philippines, we have local research that is validating the cutoff for even adolescent preggies and postnatal, post-delivery mothers. Next slide, please. And of course, the low risk, even if there is no severe or potential or moderate risk, these mothers still have to be praised for deciding to breastfeed. They have to be reassured that they are doing the best for their child, and they have to be referred and pointed towards routine healthcare services for IYCF counseling, vaccination, micronutrient supplementation, and other feeding availments. Next slide, please. All right, so let's have a quick question. Which of the following is a MAMI specific danger sign? So it's not one of the general danger signs in IMCI, but when you see it, it's really suggestive of acute malnutrition in these nutritionally at-risk infants and their mothers. Which of the following is it? Is it A, the baby does not roll over? B, the baby has bilateral pitting edema? Is it C, both A and B? Or is it D, dog, neither A nor B? Alvin, just put up the poll. Could you click on your answer? And I think this should be fairly straightforward. A is a developmental milestone of rolling over. Okay. 5, 4, 3, 2, 1. Okay. So we have almost. Okay, can we share the results? Okay, the majority still answered both A and B, but actually the MAMI-specific danger signs is B. Okay, A does not roll over is a developmental sign, but it is not specific to MAMI. Okay, thank you. Next slide, please. Okay, so step 2, MAMI assessment. Like we said, check for danger signs. By now, you've memorized fast breathing, convulsions, non-spontaneous movements, high or low temperature, and bilateral pitting edema. You've done your physical examination. You've plotted your anthropometric measurements, your Z-scores, and did possibly your bilateral edema test, okay? You've pinpointed key MAMI risk factors for our babies, like portrayed here in the picture, a baby with an obvious unilateral cleft that could probably put him at risk for feeding difficulties because they cannot latch on or attach with a good adequate seal of negative pressure. That constitutes the infant feeding risk, but you also have to remember to talk with the mother or get the mother into the health center to your point of care to be able to interview her directly. Next slide, please. All right, so we talk again and again about these general danger signs and the MAMI-specific danger signs. It may sound redundant, but pushing these seemingly redundant issues will really bring these concerns to the fore. When a mother appears out of touch, a lot of times in the workshops, and a patient comes in with SAM, I get the comment that may toyo ho yung nanay, okay? In English, it literally translates to the mother has soy sauce in her brain, implying that the mother may have lost, may be out of touch with reality, or the implication that she's crazy. Sometimes I get this gesture that the mother is crazy. But we would like to always stress that the mental health of the mother is of major concern. And in this day and age, especially with all the threats to the families, appraising or assessing a mother's mental health is of utmost importance, especially in infants who are born with these risks to survival even and normal growth and development. Next slide, please. All right, again and again, especially for the pediatricians in here, this may be repetitious, but in the field, teaching our barangay health workers, our village nutrition scholars, these are very, very important things to keep pounding on them, that it's not enough that we ask them when was the last vaccination, but we ask also in the last 2 weeks, how has the baby been feeding? And it's very important to ask the nutritional history, giving of other fluids, and we will, in the next lecture, hear about all these counseling principles and techniques to be able to ask these questions properly. Next slide, please. Okay. All right. All right, so ask the patients about recent loss of weight or failure to gain weight. Next slide, please. All right, ask if the mother especially isn't present, ask about the circumstances of her absence and all these other concerns. Is the mother a young mother? Is she afflicted with HIV or does she have AIDS? Does the baby have crying and sleep problems? And are there any other maternal concerns like illnesses, TB, etc., etc.? And of course, the use of the maternal MUAC that doesn't have these color-coded. Okay, next slide, please. Okay, next slide. I won't show the video anymore. This is a baby with a cleft. I won't show this video of Dr. Joanne Gallardo anymore, but like we've been saying again, at the minimum, get the mother and the baby in together as a diet so that you can observe at least a 4-minute breastfeeding episode and detect any feeding difficulties. Next slide, please. Sorry if I'm rushing. Assessment of mental health. It's not just A, anthropometrics, B, breastfeeding assessment, C, clinical assessment, but also D for the mother. Ask about depression, ask about anxiety, ask about distress, ask about drug abuse also, or illicit drug use, no, and all the behaviors, especially in the last 2 weeks since of the history. Next slide, please. I'm sorry if I seem to be rushing. We put in a red box these ideations maybe, or the feelings of wanting to harm herself, hurt herself, or even kill herself. These are of severe mental health flags and require urgent referral to a facility that can care for these mothers. Next slide. Okay, again, highlighting the mental health concerns. Next slide. Okay, there are forms that are available in the maternal, in the Mommy Care Pathway package. And please, when I flash the slide on references, please take a screenshot so that you can download. For any point of care, there is a form that it is best to fill out so that you can document these concerns and not allow the dyad to fall through the cracks of our health system. Next slide, please. Okay, question, which of the following is a red flag for maternal mental health? Is it A, depression, B, illicit drug use, C, anxiety, or is it D, all of the above? Can we have the poll, Sir Alvin? Okay, can you plug in your answers? I think it should be fairly clear that the answer is 5, 4, 3, 2, 1. Okay, could we share the results? The correct answer is D, all of the above should be a cause of concern. Okay, next slide. All right. For 2.2, again, this is repetitious, but again, ask the mother, what is she feeding? What is she feeding? Is she giving other fluids? Observe a breastfeed for a minimum of 4 minutes and check if the infant receives anything other than breast milk, okay? Is she receiving rice water? Is she receiving formula? Is she receiving any other liquid that is being given to replace breast milk as a breast milk substitute, okay? An occasional giving of antibiotics, the occasional giving of vitamins, although they are not needed, provided they are not meant to replace breast milk. These additional occasional giving of these other liquids do not betray exclusivity of breastfeeding. So these babies, if given occasionally antibiotics or other liquids, are still exclusively breastfeeding, provided the other liquid is not being given to supplant or substitute breast milk. Next slide, please. All right, so we just wanted to type up this so that it's more legible for you, more readable for you. And again, as yesterday, we would like to link you to the webinar day one and day two, where we talked about practical skills for these specialized breastfeeding counseling for infants with cleft. Okay, we categorized breastfeeding counseling into first line breastfeeding counseling, antenatally and immediately after birth, to be able to help a mother with positioning and attachment and suckling, okay? But if the mother still develops breast problems, we went further to talk about second line counseling. Please do view those videos, which are up on YouTube, thanks to Smile Train. And also we talked about other alternative methods of feeding breast milk in webinar 1, cup feeding, the use of the nifty cup for cleft palate patients, use of other methods to feed patients with clefts, and also the practical counseling necessary for the mothers who wish to return to exclusive breastfeeding through the process of relactation. So these practical counseling tips and skills you can all view for free on YouTube, care of Smile Train programs channel. So please do subscribe so that you can be notified of other offerings. Next slide, please. Okay, next slide, please. Okay, all right. So we go next to 2.3, which basically goes over a detailed listing of the questions that you should ask the mother or the surrogate caregiver should the mother be absent. Okay, these questions target screening for maternal health problems. So the questions will be, over the last 2 weeks, how often have you been bothered by the following problems? So I'm going to read them out one by one, just because we want to emphasize that care of the mother is also care of the baby in their diet. Okay, so over the last 2 weeks, how often have you had little interest or pleasure in doing things? How often have you felt down, depressed, or hopeless? How often have you had trouble falling or staying asleep or sleeping too much? Teka muna, parang, this sounds like me. just joking, okay. 4, how often have you felt tired or had little energy? How often have you had poor appetite or have you been overeating? Okay, there are 4 more questions. Next slide, please. Over the last 2 weeks, have you been feeling bad about yourself or that you are a failure or have let yourself or your family down? Next, have you had trouble concentrating on things such as following a conversation with people? Have you had trouble moving? Have you been speaking so slowly that other people could have noticed that your content and your pace of speech has slowed down? Or on the other hand, have you been fidgety, moving restlessly, and moving around a lot more than usual? And then number 9, which is the most serious of these questions, have you had feelings or ideations of being better off dead or of hurting yourself in some way? Okay, so these are the 9 questions. And of these, question number 9 is the most serious, and that requires emergency referral to a hospital capable of providing mental health services. Next slide, please. Okay, so these 9 questions have weights, no, and we will not go over those weights, but if any one or more of the following is detected, a score of 15 or higher on those mental health screening questions, or even if the score is lower than 15, but it is yes to question number 9 of having thoughts of self-harm, then that constitutes high risk or an urgent maternal mental health concern. And this should trigger a emergency referral, okay, to specialized care. Okay, the implications to care of her newborn are also there. Okay, whether it be from postpartum depression, actual clinical postpartum depression, or other mental health concerns that happen that occur in a mother with an infant less than 6 months of age. So at any point of care, whether at the 2 to 3 day postnatal visit, whether at the 7 to 14 postnatal care visit, or at the 6-week routine visit, or in between, when a mother brings the baby to you, or you are conducting a house-to-house visit, or a routine program like Operation Timpang, then these mental health screening questions have to always surface so that we can take care of the mother and so that she can in turn take care of her baby. Next slide, please. Okay. Question, which of the following is considered a high-risk sign requiring urgent, if not emergent, maternal referral? Is it A, low energy? Is it B, thinking of self-harm? Is it C, trouble falling asleep? Or is it D, all of the above? Okay, we're saying high risk requiring immediate hospital referral. Requiring immediate hospital referral. Okay, when we reach 50 plus for each of the letters, then I think we can share the results. Is it moving any? Okay, all right, so, oh, it's a tie between B and D. The actual answer is B, thinking of self-harm. Okay, the others are also of concern, but low energy and trouble falling asleep do not require urgent referral to a hospital. Okay, thank you very much. And I will turn over to my tandem speaker partner, Dr. Drew. Thank you very much.
Thank you very much, Dr. Mian. So just to jump off from the lecture, from her section, as we can see, the mommy care pathway package definitely underscores the need to assess at different levels for both the health of not just the baby, of not just the infant under 6 months of age, but also the mother. So a quick recap, you assess in terms of the health and nutritional status of the child, but you also assess in terms of the feeding that's being done. You also assess, of course, as what was just previously discussed, the maternal mental health of the mother, because this has a definite impact on the ability of the mother to take care of her infant properly. So just to jump over from the assessments being done, we underscore that is very important, because this leads us into the next phase where we will be doing the support and the management of these infants. But as you can see, most of these interventions are interventions that have a lot to do with how you have identified the level of risk in the mother infant dyad. So tailored counseling and actions that are necessary to address specific risk factors and problems as required. Obviously, if the mother infant dyad is of lower risk, you need to prioritize those at higher risk instead. And referral of mother infant pairs to other relevant services as required. And there needs to be continuous monitoring of the dyad's progress and well-being. So next slide, please. So if you've assessed the mother infant dyad as being high risk, these are usually the cases where you will need mommy hospital care. And the dyads receive inpatient therapeutic care for clinical conditions, depending on the relevant guidelines or the protocols. So depending on the severity and the risk factors identified in the previous assessments. Once clinically stable, the mommy care pathway package is used while admitted to provide tailored counseling and support. What you want to stress is that once the dyad is cleared of the risk factors, or is cleared of the risk that necessitate inpatient therapeutic care, we want to move the dyad as early as possible away to the outpatient therapeutic care, so that we minimize the burden that we are placing on hospitals and health facilities, because a lot of these cases can be treated on an outpatient therapeutic care basis. We want to make sure that those dyads who are at very high risk or at severe risk are the ones who are properly triaged to these facilities because they need urgent care. And we also, of course, we also want to emphasize that the age is very important, because if the infant already reaches 6 months of age, what happened? 6 months of age in the hospital, or actually at any point in the treatment, whether at outpatient or inpatient therapeutic care, once the patient reaches 6 months of age, this is a crucial time, because they already go into the 6 to 59 month age group, where we can apply the regular, for lack of a better term, CMAM protocol. So next slide, please. And we'll go through a bit of we'll try to describe what we do when we want to continue and encourage and support breastfeeding, because this is the primary intervention specifically for the infants less than 6 months of age. So usually an optimally breastfed infant will always be healthy. Of course, it's not an absolute term, because we know that of course there are always exceptions to the rules. But basically, what we want to emphasize here is that if after thorough examination, and we know that the infant really is optimally breastfed according to the guidelines and the standards that we have, the infant should not be malnourished. Usually, if this is the case, there may have been some lapses in terms of the breastfeeding techniques, or in terms of awareness, or some knowledge gaps in terms of breastfeeding, which again stresses why we have to make sure that from 0 to 6 months of age, at any point, the mother infant diet is able to access proper treatment, or proper referral, in order to identify the problems and address those problems as we go on. So when an infant becomes malnourished, it is usually preferable to attempt to improve the breastfeeding practices, or to reestablish them if they have been discontinued. So it's not as simple as saying that, oh, this child has severe acute malnutrition, let's enroll him or her into the program, let's give her RUTF, and let the program do it, and just follow the other steps in the program. That is not the case, especially for this particular age group, because for infants less than 6 months, as per global health guidelines, breastfeeding is still the key. It will always be the key for this particular age group. And what we want to stress is that inpatient staff should encourage and help to support or reestablish breastfeeding, because unfortunately, we have experiences also here in the Philippines where our health workers in the hospital should be the ones who are championing breastfeeding. But unfortunately, and I know that this has already been decreasing actually, but there are still instances where the health facilities are not properly oriented or do not know that breastfeeding should be our primary armament for malnutrition in this particular age group. So that is where the introduction of other products come in. And as we can see clearly here, that is not necessary. As long as we're able to continue and encourage and support breastfeeding, a lot of our problems for malnutrition will be addressed. Next slide, please. So for nutritional management under infants of 6 months of age, so you ask, again, it's basically going back, re-emphasizing what Dr. Ramian discussed earlier. You do an assessment of what the infant has been, what the guardian or the mother has been feeding the infant. Next slide, please. And we want to highlight, we want to emphasize again, we check and care for the mother too, in terms of in terms of health, in terms of nutrition, and also in terms of mental health. Next slide, please. So where mothers are still trying to reestablish breastfeeding, the options for feeding the infant include wet nursing by a female member of the family, cross nursing, where we won't go too much into the detail, but it involves two diets of a mother infant, where there will be a crossing of the babies so that the one tandem will be the mothers and the infants will be able to help support each other in order to induce breastfeeding, to induce the proper flow of breastfeeding in the opposite diets. This was discussed in the other webinar, but I think for lack of time, though, we will need to proceed with that. But the idea of cross nursing is that there are two diets of infant and mother. So you exchange the babies so that the breastfeeding will be stimulated in both pairs. And we want to use donor human milk if available, observe proper guidelines on storage, and alternately feed the infant by cup. As much as possible, we don't want to rely on using bottles. There are ways of feeding infants breast milk even without bottles. We can use cup feeding or supplementary suckling techniques. Basically, we want to reduce any external stimuli that might hinder our efforts at sustaining or reestablishing breastfeeding. So again, the aim of treatment is to stimulate breastfeeding, reestablish, and sustain it. Next slide, please. So we won't go into detail here, unfortunately, but in inpatient therapeutic care, these are the commodities that we can use, but specifically for the under 6 months of age group, if there is no breastfeeding breast milk available, what we can do is use diluted F100 therapeutic milk. Next slide, please. We won't go into detail because it takes a bit more. It's a technical matter, but there's basically a formula that you can follow. We want to stress though that these F75 and F100, they are not formula milk. So this is not going against the milk code here in the Philippines, or maybe other countries also have a similar guidelines. It is not. We are not introducing formula milk to these children. These are therapeutic milk products, and these are specifically designed for children who have severe acute malnutrition. So F75 and F100 are specifically for SAM patients. For children under 6 months, breastfeeding and breast milk is still best. If not possible, then that's when we may need to go to diluted F100 milk. Next slide, please. So again, we go back to the different steps. We continue to praise efforts at breastfeeding. The infant should be nursed at a separate space from older malnourished children. And basically what we're saying here is that we kind of form a mother support group of mother-infant dyads who are breastfeeding. This has proven to be very helpful in order to encourage the atmosphere of breastfeeding. This area may be useful to bring breastfeeding mothers together for mutual support and counseling by the staff. And the step 5 is to give counseling and support for any issues identified during monitoring in relation to attachment and feeding of the infant. So all throughout the process, the mother-infant dyad should be monitored for any problems, because it's always better to address the problems as soon as possible in order to ensure the smooth reestablishment of breastfeeding. Next slide, please. And again, we cannot emphasize enough. Continue with breastfeeding and breast milk feeding, and you monitor the weight gain as well. Next slide, please. So that was for inpatient care, but as you can see, actually the guidelines also for outpatient care are pretty much the same as well. And you have to make sure that there are regular visits of until the infant reaches 6 months of age. You tailor the counseling and support depending on the identified risk factors, whether it's on the infant side, on infant feeding, or whether it's on the maternal side, if the mother is sick or has other problems or has mental health challenges as well. What is important to emphasize, whether in inpatient care or outpatient care, or whether the baby is actually doing fine, if the baby's condition deteriorates wherever in the pathway, we should be able to identify where to properly refer the patient to, whether it is an outpatient or whether it is in the hospital, depending on the risk factors and the assessments that we have been doing in the past slides. Next slide, please. So one of our main interventions is counseling. This actually will be leading into the next the lecture after this MAMI lecture, where we basically need to emphasize that all mothers should receive counseling and across different topics, whether it's for relaxation, for infant crying and sleep, nurturing care for early childhood development, father community support, family planning, timely introduction of complementary foods. All of these are very important topics that the mother and infant dyad need to be counseled on. It seems very straightforward, but from experience, there are a lot of people who actually are requesting support in terms of counseling. So it's a very important skill that needs to be emphasized as well. And there are ways for us to be able to strengthen the counseling capacities of our health workers. Next slide, please. So interventions for MAMI-specific risks. So again, we have to identify the specific risk factors. So infants born preterm or low birth weight, congenital anomalies, multiple birth, if the mother is young or the adolescent mothers under 19, if mothers or the infants are infected with HIV/AIDS. Here we also stress the nutritional status of the mothers. In other countries, it was already mentioned that mothers are also, the MUAC of the mothers are also taken. In the Philippines, the guidelines are not established. What you can see here is that for the flag here is that if the MUAC of the mother is less than 230 millimeters, then they are classified as malnourished. It is not a clear guideline in the Philippines. In other countries, this is what they are doing. So this definitely needs to be investigated on a country-to-country basis. But just for your information, it might be included in the future guidelines that you will also be taking the MUAC of the mother as well. So and again, for whatever risk identified, it is after identifying the risks, that is how you will target the interventions, whether it is through tailored counseling for the different risk factors. And also, basically, the ideal target diet is optimal, exclusive breastfeeding for the first 6 months of life. We cannot stress that enough. Breastfeeding really is the key to helping address malnutrition, especially in this particular age group. So next slide, please. And again, maternal mental health risk support and management, depending on the severity of the assessment of the risk to mental health. If for mothers identified with severe mental health risk, you have to do urgent referral to specialized mental health and psychosocial support services. If it's moderate, sometimes you can do counseling and support based on the packages available. And if it's low risk, you continue with your routine healthcare and your IYCF counseling. And also, but throughout the process, if there is any deterioration, you always refer and assess and assess and assess. Throughout all of these steps, we are all together in the pathway, so that if there are any challenges that come up, we are able to identify and refer to the proper area, to the proper treatment facility. Next slide, please. So again, referral. And through referral, there are many aspects of health programs that we can refer to, whether it's through community support groups, also through vaccinations, social welfare programs, food and security services, specialized maternal mental health support groups, disability services, and PMAM services. As we were stressing earlier on, it's the PMAM program actually stresses the integration. If you can see, actually, that's one of the changes that the Philippines decided to adapt. The global term is community-based management of acute malnutrition, but the Philippines wanted to go a step further. It's Philippine integrated management of acute malnutrition, because the end goal is the integration of all health services in order to properly to provide proper nutrition services for our children. It's still under development. We're not quite yet there, though. But at least we know that is the goal. Integration across different health services, so that if any problems arise, we are easily able to refer to where these mother-infant diets or these children with malnutrition can avail of proper services. Next slide, please. So for monitoring, growth is important but not the only sign. If the mother-infant diet is showing sufficient improvement, you can reduce the frequency of the engagement or of the visits, but of course you still have to have regular contact just to make sure. You just have to make sure that there is no deterioration. If the infant or mother diet is not progressing or deteriorating, then that is when you observe more closely and or refer as needed. So next slide, please. And as mentioned earlier, it's very important to be aware of the 6 months of the age of the child, because if at 6 months of age you have to do a reassessment. If at 6 months the diet status requires continued support, then you transition from mommy care and into the regular CMAM program. You have to detect if there are still any ongoing or new issues detected, and you refer as needed. Next slide, please. And then, so again, at 6 months of age, the diet status, you have to check the diet status if they require continued support upon exit from the mommy care. And even if recovered, you still continue with routine health care and IYCF counseling. So we'll just go back to our pictures earlier. So this is the child that we were discussing about that was identified in Basilan, and as mentioned, it was a far-flung island province here in the Philippines. It's very, very far from the usual access to health services. Access is very limited. But through the interventions of Ms. Sagaral and I think Health Organization Mindanao and other agencies and other partners, the child was identified and was what was done was that because breastfeeding could not be established immediately, or there were challenges, the baby had to avail of breast milk, but a milk bank was not available in Basilan itself. So our health workers really are made of something else. The passion can be clearly seen. The health worker that I was talking about earlier actually went to the nearest province in the mainland of Mindanao. So she had to travel by boat to Zamboanga, where she could get the breast milk, and she would be bringing the breast milk over back to Basilan in order for the child to be able to avail of services. And as we can see in the picture, Alex, if you can click, after some time, here the baby is slowly recovering, but I'd like to show the last picture. Where will you look at that? How miraculous this particular program can be. And it was actually just by reestablishing and protecting the breastfeeding and making sure that the child had proper access to breast milk in order to regain the nutritional status that the child had lost. So as you can see in the pictures, it's very distressful to see. It's very distressing to see these children, because these children are the mothers as well. They did not want this. Nobody wants this to happen to their children. And sometimes, unfortunately, these things just happen. But when these things do happen, it's very important to know that that there is a solution. And sometimes these things are easily accessible and well within our grasp. So before, maybe I think some of our health workers here in the Philippines can relate that before this program was established, when you find a child who was identified to have malnutrition at this level of severity, sometimes you would say that this could be a death sentence for these children, and that they would be resigned to their fate because basically there was nothing that they could do. But there is something that we can do, and it's very, very accessible, and it's actually something that we are already doing. So a big salute to our breastfeeding champions and those who are making it possible. This is just one story. Unfortunately, I'm sure that there are other children who we may be missing out on, but that all the more underscores why we need to strengthen this program. We need to strengthen all aspects of it, whether identification, treatment, etc., etc. Because the pictures speak for themselves. It can make a world of a difference for these children, and we can make it happen. So next slide, please. So just to wrap, we're nearly wrapping up this lecture, and this slide is quite a busy slide, but basically this just goes over all that we discussed in this lecture. So I won't go through the details, the individual details, but we would just want to emphasize that there are steps that we need to follow for the program. But it's basically, we have to identify who these children are, and we have to screen for the risk factors. We have to screen for the different factors that will help us identify the level of risk that the infant and mother dyad may be facing. This will help us to then refer them to the proper treatment facility, whether they can be treated at the community level, whether they need to be treated at outpatient care or inpatient care. And throughout the process, we need to observe them all throughout in order to determine, to make sure that they will not deteriorate, and our progress will be towards them getting back and getting better and better and getting back to normal nutritional status. So next slide, please. So I think this is a summary slide. In summary, MAMI aims to identify and support the nutrition of small and at-risk infants under 6 months and their mothers. The MAMI Care Pathway links with and uses existing systems and services to ensure feasibility and relevance across different settings. Interventions focus on treating the mother-infant dyad. You treat both the mother and infant. You don't treat the infant just by him or herself. And lastly, integrated care approach is strengthened through routine screening, identification, assessment, immediate treatment, and referral as needed. So with that, we end our lecture. Thank you very much for your attention. We will now turn you over to our third and last lecture on counseling. And I would like to tag in Dr. Donna for this lecture. Thank you very much.
Thank you very much, Drew. Thank you, Dr. Mian, for such a comprehensive lecture delivered quite efficiently. To acquaint our participants here, usually when we do the face-to-face when we do the face-to-face training, this would be spread over at least 2 whole days. So here we've tried to, as much as possible, just utilize 2 afternoons. And so I hope you bear with us. And this is now the tail end of this 2-day webinar. And as mentioned by Dr. Drew in a previous lecture, counseling takes a large role when it comes to problems such as acute malnutrition, especially when we have to enjoin families because we are taking good care of children, and it would be the adults that we need to rally and we need to make advocates of so that they will accept and that they will comply with the life-saving measures as has already been illustrated. So we cannot emphasize enough how important it is to involve families and communities in the fight against malnutrition. And that with this malnutrition, there is a stigma, not unlike the stigma for having a cleft. And that stigma is borne not only by the patient, but also by the family as well. So bear with me, this will probably take around 20 to 25 minutes. So it's just important for us to bring this full circle and emphasize the importance of counseling. So next slide, please. All right, so for our objectives at the end of this module, the learner will be able to describe what counseling is in this context, to distinguish the stages of behavior change of the caregiver, and also to learn the different skills necessary for a successful counseling. Next slide, please. So in our case right now, counseling is defined as giving advice and support to the caregiver in order to help them, to guide them go through this problem that they are facing, and hopefully also guide them to make important decisions that will hopefully lead to the best outcome that there could possibly be for their child. So this is definitely not counseling that refers to professional guidance of an individual that utilizes psychological methods. So just as a disclaimer. Next slide, please. So, and as far as our key concepts are concerned, we consider the caregiver, as we have already emphasized, as a key partner in the recognition, monitoring, and treatment of acute malnutrition. And so the health worker should be able to utilize the caregiver, the family members, to become partners and ensure the best outcome that there could possibly be. Next slide, please. So this is just a study that we came across, and it really emphasized the importance of the role of the mothers in the role that they have in increasing the treatment coverage of severe acute malnutrition. And so the study was done comparing the skills of mothers and community health workers in measuring MUAC of children. And from here, it was really highlighted that mothers can become the focal point in scaling up community identification and management of severe acute malnutrition. So next slide, please. So first, we'll go over the stages of behavior change. So at the end of this session, you will be able to describe and distinguish the stages of behavior change that the caregiver would be in at regarding the care of the child with severe acute malnutrition or moderate acute malnutrition, as the case may be. Next slide, please. So you can see here the steps. So a person goes through different stages and through which a change in behavior could occur. So at first, there could be unawareness of what is going on with the patient, for example, has never heard of what the patient might possibly have and what could be done about it. And then on the next step, it's actually thinking about it. So the patient or the caregiver is actually past being unaware and is actually hearing about the condition, but the patient is still mulling over it, or rather the caregiver is still mulling over it, but is not actively doing anything about it. And then for the third step, it's trying it out. So meaning, okay, I'm aware, I have more information, and so let me try out what I can potentially do, in order to help out or rectify my child's situation. And then fourth is maintaining, that's the top of the ladder that you find there in front of your screens. So this is to continue the behavior that the caregiver had initially already tried and successfully do so, because now she's maintaining the behavior. There's actually a fifth step in this ladder, but it's not pictured there. That fifth step would be advocacy, in which the caregiver will not only continue to the practice or the behavior that would be helpful for the patient or her child, but rather would also be encouraging others to do the same. She would be a focal point, if you will, of information and proactive in encouraging others as well. Next slide. So we have your situation just to illustrate what we've been talking about. So take, for example, the case of Anna, who is the mother of Annie, and Annie is identified to have severe acute malnutrition during a routine follow-up health visit. So this is passive screening then, if we want to put the pieces of the puzzle together here. So during passive screening, picked up to have severe acute malnutrition. So at that stage, Anna was taken unaware, So she was really unaware that that was going on with Annie. And so, and as far as the healthcare worker is concerned, the approach to counseling would be to explain what severe acute malnutrition is to Anna, what would be the benefit of having identified severe acute malnutrition. So it's always good to focus on what is positive in a potentially negative situation, so that we can rally Anna towards the positive behavior of compliance towards treatment for Annie. So typically in a face-to-face training, we would have this acted out, these situations acted out, but we're unable to do that in this format. Okay, next slide, please. So the first step was being unaware. The second stage of behavior would be thinking about it. So in this case, just to illustrate, we have Juana, who is the mother of Juanito, who was also just then identified to have severe acute malnutrition, and is now being told that there is need to bring her child to the outpatient treatment facility. She is aware of severe acute malnutrition because, in the Philippines, we say may mga marites, no? So there's the latest, mare, there's the latest. So she was chatting with her neighbor, and her neighbor also knew about severe acute malnutrition. And her neighbor happened to be Anna, whose child was Annie from the first example. So they were able to chat about it, and therefore Juana was able to get more information about severe acute malnutrition because Anna was her source of info, of facts, and hopefully not fake news. And so the approach to counseling then, if Juana should come over and present to the outpatient treatment care facility, is to inform her more about the options for treatment, and then also help to guide her through what would be the facilitators and the barriers in carrying out the treatment for her child Juanito in the outpatient treatment care facility. So in doing so, we are already trying to help Juana problem solve her situation, and hopefully by doing so, she would then be more compliant towards the treatment in the outpatient treatment facility for Juanito. So next slide, please. Okay, so the first step was unaware, and then second is thinking about it, and then the third behavior stage is trying it. So now to illustrate, we're going to talk about Teresa, who is the mother of Teresita. Again, another child identified to have severe acute malnutrition and brought to the outpatient treatment facility. And for the first time is being counseled. So going back again, and if we're going to have another installment and focus on the actual treatment of SAM in the OTC and ITC, you know it's not just one round trip. It's going to require several trips to the treatment facility, even counting in the fact that there could potentially be home visits as well for the patient. So in as far as Teresa is concerned, we want to engage her to continue on trying the treatment that has been offered for her child. So we have to encourage Teresa then to continue the visits to the OTC. We have to make it again as a positive experience to be doing so. Because as we know, like from the first lecture, what we had mentioned, right? That there would be barriers for compliance. And these are typically now social determinants of health, like the cost of transportation, the distance to the health facility, opportunity costs. So we really need to be supportive of Teresa in this case. We need to praise her for her persistence and her efforts. And again, if there are continuing issues that need to be addressed, barriers that would deter Teresa from being compliant with Teresita's treatment of schedule, then we have to help problem solve those things with Teresa so that she will keep on trying, she will comply with the treatment regimen. Okay, next slide, please. So now, so we've covered 3 stages. So that's being unaware, thinking about it, trying it. And now the next is maintaining it. So to illustrate, we have Lisa, who is the mother of Lizzie. And Lizzie, again, identified to have severe acute malnutrition and already being brought to the OTC. But then, as you would discover, as we said, there's a whole different, like 2 days worth of lectures and practical demonstrations when it comes to unraveling the details of OTC and ITC. So it could be that within that span of monitoring during the treatment phase of OTC, there arose an indication for, in this case, Lizzie to be brought to ITC after 2 weeks because she wasn't responding adequately to the treatment on hand with RUTF. So this is quite a stumbling block, a challenge to overcome for not only for Lizzie, but also all the more for Lisa, right? So we said, we are a patient-centered treatment, but we also have to be family focused because we know how important the parents are, the caregivers are as partners in the treatment of their children. So we have to ensure that Lisa, who was already trying it, will continue maintaining it despite this stumbling block. So we have to compliment, we have to praise Lisa, continuing her care of Lizzie. Explain to her clearly why there is now a need to carry on with treatment, not in OTC, but in ITC this time. And again, part of what we will offer is to help problem solve any of the barriers or deterrents for Lisa to stick to complying, to maintaining with the treatment regimen that is prescribed for Lizzie. Okay, I hope that was all clear. Next slide, please. So in terms of counseling skills, so we have that first knowledge about what the stages of behavior are, and these go hand in hand then with how we employ or when we employ our counseling skills. So at the end of this session, you should be able to describe the different skills necessary. And this will include establishing rapport, active listening, asking the right questions, giving advice, ensuring understanding, helping the caregiver formulate a plan or a solution. And inevitably so, we have to do it at times. We don't like it, but we have to break the bad news. So how do we actually do this? How do we communicate? So next slide, please. So for establishing rapport, what is rapport? Rapport is getting connected, having that connection with another person or having that relationship. So it's very important to be friendly and respectful. speak in a gentle voice. I know that there are some people who innately can be quite forceful in their manner of talking. So if we are aware of that, we should keep a mental reminder to modulate our voices and be gentle as possible, because typically children who or families who would have this situation or issue of acute malnutrition will be families who are coming from the lower social economic strata, right? So they would be sensitive and even more so coming in for this problem. And then talk to the family, talk to the caregiver, and then try to explain as simple as possible what is going on with the child, what are the steps that are necessary. So we have to make it clear and we have to keep it simple. And of course, it's always going to be great when you talk in the same language. No? Sometimes kasi, there would be the situations that would arise, particularly in hospitals. For example, here in Metro Manila, and the patient comes from another province, and there would be another dialect that's being spoken or another language. So it's really important to establishing rapport as well, to be familiar with each other's language or speak each other's language. Okay, next slide, please. So skills for asking and listening. I know you've heard this before, but we'll say it again because it's important. So ask open-ended questions and not close-ended questions. So close-ended questions, you know that, right? It's answerable by either yes or no. So you may just ask, has the baby eaten? So the answer would be a yes or no. So transform that into an open-ended question and then ask, what did the baby eat earlier, right? So, and so you get a narration out of the caregiver, you know? And that can also help build your rapport, because during this time you're going to show that you're actively listening to your informant, and you manifest this by your body language. I'm sure you're all familiar with this. You have to maintain not a, you know, like what they say, like closed posture, not to maintain a closed posture, but rather an open posture when it comes to body language. Maintain good eye contact, right? That's always something that is important, just to also convey the message that you are listening and you have their attention, or they do have your attention. And then reflect back, right? What's reflecting back? Reflecting back is just basically saying again what the patient or the caregiver, in this case, had already told you about the situation of her child. So it may be just as simple as the mother having said that, oh, my child was actually having diarrhea since yesterday, and she wasn't eating so well. And so, and then without any judgment, just reflect that back and just say, oh, okay, so your child, say the name. It's always good to say the name. Has been having episodes of diarrhea, right? So it's just reflecting back and hold the judgment. You know? For those of us who are trained in the bigger hospitals, government hospitals, or even just the busy hospitals, there's always that following question. So why didn't you take her here earlier? Right? So we have to hold back on those, because the last thing that we want is to antagonize the caregiver and therefore dissuade her from becoming a partner in the care of the child. And then we need to empathize. So a mother may say that it's really exhausting having to breastfeed all day. It's like this child is always connected to me and I can't really do anything. So to show empathy, the healthcare worker might say, that is so exhausting and that must be very difficult for you, right? So it shows that you can actually place yourself in the position of the mother and that you are trying to channel her feelings as well, okay? So I've already said, do not use judgmental words. So very important, when you do active listening and then you're asking the right questions, is also key to establishing your rapport. Next slide, please. Next slide. Okay, so this is just a picture, and we're thankful for our mother support group partners from Breastfeeding Bicolanas for providing us these visuals. And usually, if this were face to face, we'd have an open forum, and I'd be enjoining you to tell me what is going on here. So basically, now. Just to sum it up for you, there is a conversation going on between two ladies. Presumably, one is counseling, and the other is the recipient caregiver. And as you see here, they're in eye level, so presumably there's eye contact, and the body language could be better. They're both sitting with crossed legs, but it seems like the woman who is the recipient of the counseling has a forward stance, no? Even though her hand is on her knee, it seems that there's a forward stance. So her attention has been captured. Okay, next slide, please. Okay, in this case, again, another photo provided to us by our partners in Breastfeeding Bicolanas. Thank you very much. In this case, you could actually think about it two ways. In terms of behavior stage, where is this mother at? It's not being unaware, and it's not about thinking about it. She's already trying it. So in this case, what's being tried is what? It's expression. So it's manual expression for breast milk. No? I would just have to comment because we don't have the exact details surrounding this session here of helping the mother, of teaching the mother how to do manual self-expression. Typically, what we would advise would be for the healthcare provider to show, and usually we'd encourage showing by using a model rather than directly on the mother, unless they had already agreed that the mother was quite comfortable to undergo this exercise with the person who is counseling her. So there has to be that respect for boundaries, for sensitivities. As I said, we don't know the context of what's gone on in this session. It may very well be that they had already talked about it. And so now the mother is being shown the steps, no, of how to do breast expression. Okay, next slide, please. Okay, so here we have to thank our partner from Baguio General Hospital, Dr. Eleanor Cuarte. She was here yesterday. I'm not so sure if she's here today, but we're thankful to her for having provided us this photo. As you see here, we have a mother, presumably with a preterm infant, and that's being put on skin-to-skin position. And this is much in line with our essential intrapartum and newborn care protocol that helps with the initiation of early breastfeeding in the first hour of life. No? So you have three healthcare workers here. Again, not entirely sure about what the situation is. Not entirely sure if they've already done in terms of stages of behavior, made the mother aware of what unang yakap is, as we call it here, and then beforehand, even prenatally or maybe even early on in labor, if they've already talked to her about it, giving her more information about the benefits of doing skin to skin, and therefore now they're trying it with her. No, ideally in this situation, shouldn't be a crowded experience. It shouldn't require three healthcare workers to help a mother, especially with the ongoing context of the pandemic. But again, we're not so sure what were the circumstances surrounding this photo. Just to show that that these are situations that we will find ourselves in as well, and so we must utilize our knowledge now about the stages of behavior change as well as counseling skills. Next slide, please. All right, so you have here a woman who's doing a survey, presumably about infant nutrition. And you see here at this stage, the woman who's doing the survey is standing upright and the mother is down. And so there presumably is a position of dominance versus the mother, for which the mother still has to look upright. Right. So, and as far as body language is concerned, she's holding her clipboard. It seems like she's in a hurry. So it seems like to convey that there isn't time to really listen to this mother. So these are things, I know that we're very busy in our workplaces, but we should be cognizantly aware of what our body language is actually revealing about us, right? As we said, we need to build rapport with these caregivers, with families. Next slide, please. Okay, so here we have a better situation, I would say. You have the surveyor person who is in fact sitting with the caregivers or the family and explaining something, it seems, and she has the attention of the caregivers. So it seems like they're very comfortable with each other already. And so if we consider about the stages of behavior, she may still be at the stage of probably thinking about it, right? Because the healthcare provider or the surveyor is already explaining things to the caregivers or to the family members. Next slide, please. Okay, so here again, another counseling session with a mother and an infant. Again, props to our partners. In this case, it's Dr. Marge Sibayan who provided us this picture. And it shows eye-to-eye contact, same level as the mother and the healthcare provider. Probably it will depend on how long the duration of this counseling is. If the baby is asleep, perhaps just to make the mother feel more relaxed, the baby could be given over to the father if the father is present or another caregiver, so as to also capture a fuller attention from the mother to the caregiver. They're knee to knee at this point, so it seems like they're comfortable with each other as well. Okay, next slide, please. Okay, so again, another photograph that's depicting counseling with regards to breast expression. I think we've covered this, and thank you to, again, Breastfeeding Bicolanas for providing us with your photos. These are very helpful for us during these training seminars. Again, same comments as well with regards to actually using the mother already as a model for a demonstration. Just have to go through the nuances of sensitivity and that the mother agrees to this process as well. Next slide, please. All right, so skills for giving relevant information. So it's very important to acknowledge what the caregiver thinks or feels. It is important not to just totally contradict or disagree with whatever the woman says. No, I can probably give you an example, and that being in the vaccination drive for COVID-19, one mother said that, we're very afraid about the possible side effects for our child. And then one doctor says, just believe what I say, right? That's very doctor-centric. When in fact, we should try to understand where this caregiver is coming from and show some empathy. And so in that, we are able to feed information to her based on her present understanding about what's going on. And we should just use a very simple language as well. Next slide, please. Okay, so we need to check understanding. So we use open-ended question and we praise when appropriate. So how do we check for understanding? So we ask them questions back so that we are able then to assess whether they have actually accurately gotten in or digested our exchange of information. And if that were the case, then we praise the caregiver for having done so. Next slide, please. All right, so skills for helping the caregiver to formulate solutions. So we really have to sit down with them. It's like planning, and it's like having a problem tree. I don't know if you're familiar with that. So we have to take note of the particular contexts or factors. And so we help the families to go through each of these. And we then also employ what we have learned about active listening and asking the right questions and not closed-ended questions. Next slide, please. All right, so for breaking the bad news, very difficult. It could be the condition of a SAM child is deteriorated progressively. And so how do we do this? So very effective is nonverbal communication. It's not like we're going to the mother and say, your child is going to be dead. No, not terse like that. Usually we have to be gentle. We have to be empathic with the family. And so we use nonverbal communication. Sometimes as healthcare workers, I found myself in that situation as well. It's very hard really to put into words, right? So we do with nonverbal communication. We are kind, we are gentle. We do things to assist the needs of the family as well. If you have that rapport established, you can touch her as accepted or appropriately. And you should not leave the family alone until such time that they are ready and they have manifested that they are in that state of mind or that they are capable of being left alone. Next slide, please. So in terms of verbal skills, we use a very simple language. We should step away from using technical terms and we have to speak softly. Again, be mindful of cultural sensitivities. We can ask if there's anybody, if there is only the caregiver, a solo caregiver, we can ask if there's anyone else who she would want to be there with her. And probably we can facilitate for that person to be there with her. And then we can also express our regret over the situation that had transpired. Next slide, please. Okay, so in summary, counseling in this context of, of the diagnosis, of the management, all the way to discharge in as far as acute malnutrition is concerned. In this context, so that's our context, is really to help and to guide the caregiver to make decisions for her child. And that we need to be cognizant of the stages of behavior change, because in doing so, we are able to employ the different skills that are necessary that will help us to be successful in counseling. So we need this knowledge. We need to be consciously aware to equip ourselves with this and to practice them over time. So thank you very much for your attention. And that is the end of our 3 lectures for this afternoon. May I invite my co-speakers for the day. That's Drs. Silvestre and Dr. Buku to also join me and open up your cameras so that we can just go dive into our Q&A portion. I've been looking over at the Q&A box and really there's a good question here coming from Claire Mogol. And really her question is something too that we keep on asking ourselves as well, because this whole PMAM program should really be, oh hi Alay, should be at the hands of the local government. So the question coming from Ms. Claire is if that there is a policy coming from the Department of Interior and Local Government, or the DILG, that expresses their support so that this PMAM program will be properly implemented, or is there a directive coming from DOH? So I see that Dr. Buku had already given the intent to answer this question live. So I give you the floor, Dr. Buku.
Thank you, Dr. Donna, and thank you, Dr. Claire, for that question. It's a very important question, actually, and actually, it's something that's readily answered. Sorry, this is the person who we're doing the program for. But just to emphasize, though, in the trainings that we usually do for PMAM, we actually have a module on governance, and it's highlighted there that we have that the Department of Health actually already has an administrative order. It's AO 2015-0055 that the PMAM program should actually be integrated into routine health programming. So there's actually no excuse for any LGU within the Philippines or any area within the Philippines. They are actually obligated to already conduct the programming. However, as we can clearly see, and by the virtue of asking this particular question, we know that that's not the case. And there are a lot of areas still reaching out to request assistance on how to set up a program. And it's a very good question by Dr. Claire, because it emphasizes the role of the LGU. What other LGUs have done is that they have also enacted local or regional level ordinances So for example, at the provincial level, at the municipal level, or at the regional level, some of them have also enacted policies, basically, just to drive home the point that the PMAM program is in existence and it should be implemented. But in terms of policy, the AO20, the administrative order from the Department of Health should cover that actually already. And I would recommend also in other countries. I'm not, of course, it depends on the systems, on the health systems that are existing in your particular country. But having these policies are important in order to give you the proper support, because when these policies are in place, that is when you are able to push for the training, for the supplies, for all of the other elements that are necessary in order to push to implement the program properly. So there.
Great. Thank you, Dr. Buku. Dr. Silvestre, is there anything that you'd like to add to that?
No, nothing to add. But hello, Alay.
Yes, hi, Alay.
Breastfeeding dad.
I'm so sorry.
Okay, so I guess then, because Dr. Buku mentioned supply here, and that's tied to the issue of policy and governance as well. We do have a question also in the Q&A box coming from Dr. Maldonado from Batangas. And so now comes this question of what is the availability right now of F75 and F100 for dissemination to different government hospitals. But before I say anything, just as a disclosure, we're not with the Department of Health. So, and with that, I will pass it again to Dr. Buku.
Thank you, Dr. Donna, and thank you, Dr. Maldonado, for your question. Shout out to the health workers in Batangas and the RPMM warriors in Batangas in region 4A. But yes, the disclaimer is very important because basically the Department of Health or whoever is the government agency involved in your particular area, they are the ones who are more equipped to answer your question. Unfortunately, there is a consistent problem with supplies as of now. F75 and F100 are not readily available. In addition to that, unfortunately, these supplies are not locally available. So it's not something that you can buy over the counter. Currently, what has been done in past years is that the Department of Health is the one who is procuring on a national basis. That's why the Department of Health has regularly been reaching out to the different local governments to determine the actual level of malnutrition, and from there they estimate what the number of supplies that need to be ordered. There have been some glitches along the way, and unfortunately at this particular point in time supplies are not readily available. But what is important is that it stresses the fact that it's very important for the LGUs in your areas to relay back to the Department of Health the prevalence and how many children have malnutrition in your particular area, because that they will be able to emphasize to order the supplies that you need. In particular, I also want to highlight that in your area, ma'am, in Dr. Maldonado, in your area in Batangas, we mentioned before that PMAM was born in response to disasters and emergencies. Actually, the recent volcanic eruption in Taal, the Taal volcano erupted. It necessitated the bringing in of supplies, to the particular area. So I hope that actually Batangas was able to avail of some supplies. But again, I think actually this is one of the advantages of the MAMI component. I just want to bring that in because MAMI is something that actually we can readily implement, because as emphasized repeatedly, what is the primary tool in addressing malnutrition in infants under 6 months of age? It's breastfeeding. And that is something that is that a lot of areas are very strong in, and something that we can actually do without necessarily ordering the supplies. So I think that is an area that we can particularly move forward. But in the interim, there are actually a lot of people in this room who are better suited, who are affiliated with the Department of Health, who can answer that. Also on the flip side, they also may have their own gripes in terms of the lack of supplies, but hopefully this is something that will be addressed in the future.
All right, thank you. Thank you, Dr. Buku. I hope that was sufficient to answer Dr. Maldonado. We actually have more questions in our Q&A box, and this concerns both about breast milk and breastfeeding. So probably I'll volley these questions over to Dr. Mian Silvestre. So we have a question here from Shukriya Saeed, and she's asking if a mother is already malnourished and the child or the infant has SAM, should she still give breast milk? And then follow through with Nadine Casino's question, which is donated breast milk a better option to substitute for F100 supplementary milk? I guess this may also be a question pertaining to the care or in the management of acute malnutrition in infants. Thank you.
Okay, thank you, Donna, for giving me the difficult questions. Thank you, Sukriya, for asking
Of
them,
course.
and also for Nadine. Okay, so let's start with some premises. Let's start with some tenets, I guess, or principles. Breastfeeding to us is not just a feed. It's not just food. Okay, it's not just nutrients, but it's also nurturing, and it's also immunoprotection. A lot of times, even as pediatricians and as neonatologists, we would memorize content, okay, of breast milk, content of formula, this and that. But the missing messages referred to the other aspects of the benefits that breastfeeding and breast milk can afford in terms of both short-term and long-term benefits. Okay, so let's go to my answers. For example, for the malnourished mother. Okay, I do know that it's only in very severe degrees of malnutrition can a malnourished mother's lactation fail. So, for example, in mothers with anorexia nervosa, where their hormonal status is totally disrupted, no, then her milk production might fail. Okay, so really thin, really undernourished mothers, as in anorexia nervosa, where even their menses disappear, their menstrual periods disappear. So in undernourished mothers, it may affect the quality of their breast milk, but their lactation, the milk production, may not fail until very severe degrees of malnutrition. So if you have a mother who is malnourished and a baby who is also undernourished, more so if that baby has a cleft, okay? I don't think that either of their conditions, the maternal undernutrition nor the infant undernutrition, contraindicate breastfeeding. What do I mean by that? It doesn't mean that because a mother is malnourished and her baby is likewise malnourished, that you should separate them and not allow them to breastfeed. What we want to do and what we've stressed throughout our 2 webinars so far is that the mother and the baby should be kept together and treated as a dyad. While the mother is being nutritionally rehabilitated, she should be allowed to still carry her baby, do skin-to-skin contact, offer her breast, while her baby is also being nutritionally rehabilitated. That way, even their psychosocial dependency on each other is not clipped, no? So keep them together, do not contraindicate breastfeeding, do not stop them from breastfeeding, but rehabilitate them simultaneously. And that means both nutritionally and psychosocially. Understand their predicaments and make sure that as you secure them as a dyad, you don't put them in a place where once you separate from them, that they'll just fall back into that predicament of poverty, of unemployment, etc. So it's a more holistic, rather than saying malnourished ka, your milk is low quality. Disempower her and say, no, I'm gonna just give the baby formula and you formula too. So we give it a try before saying that last resort, you go to artificial formula. So I hope that answered Sukriya's question. What was Nadine's question? Hello, Nadine.
And Dean's is donated breast milk a better alternative than F100
Okay.
as a supplement?
Okay, but of course, you sensed my bias, no? Donated breast milk has immunoprotection, and F100, diluted F100, does not. Okay, so I think to me, the benefits of providing the cellular components of our immune system, the mother, being able to pass cellular components and also antibodies of whatever microorganism she herself is exposed to in the environment, tips the balance in favor of giving donor milk rather than F100.
All right, thank you very much, Dr. Me. And I've been scanning over the chat box, and I think there were questions here, but I think these have been answered as well. Qualms about the appropriateness of breastfeeding for acutely malnourished infants with cleft, and I think that has been addressed as well in the chat box during the discussions.
But of course, Donna, to see is to believe. So we have all the videos in our webinars contributed by mother support groups themselves of their handling of babies with clefts, some of whom were at the very least moderately malnourished, and with breast milk and breastfeeding, combinations of either relactation, giving of donor milk, alternative feeding methods like the Nifty Cup, etc. Because we always have to think holistically, not just calorie counts, but and weight gain that's faster, but not necessarily of better quality. Correct. So we have shown, and our mother support groups have shown time and again, that nothing beats breastfeeding, and it gets them out of those social determinants of health, of the very thing that put them there. Okay.
As we say, breastfeeding is always the safest and most secure source of nutrition and feeding for our infants. So just going over the chat box as well, I know in my previous lecture on counseling, I was querying about the circumstances or the context of that picture coming from Baguio, and Dr. Eleanor Cuarte is present with us. Thank you, Dr. Eleanor, for being with us and has explained the situation in that picture, in that the mother actually had twins who are preterm. And so the hospital staff were really there to support her. And because of the ongoing pandemic, family couldn't be with her in the facility. So there's really need to rally the residents and the nurses in that picture to give support for the mother to do KMC and breastfeed her twins. We also have other comments as well coming from Breastfeeding Bicolanos. There's a lot of requests for counseling as well in their area. And then again, another comment that it is important for families to know that infants or young children who are prescribed therapeutic feeding should just really be fed those feeding commodities themselves and not to share with the other children. And okay, so there are questions still that are coming on our Q&A. Oh, this is a good one. So the mother is mentally challenged. I'm not quite sure what mentally challenged is meaning. Is there really a cognitive issue? Is really more of a mental wellness issue, but in either case, the child has bilateral cleft, I guess palate we're referring to, and also has acute malnutrition. So how do you go about promoting breastfeeding in this case? And then there's a question here about the availment of the mist cup, but over back to, who wants to take it first? Probably Dr. Mian, about the MAMI issue here.
Or Drew, of course, we follow the MAMI intervention care pathway. Screen first, use the mental health, maternal mental health questions to try to screen so that the particular mental health dysfunction, disorder can be identified, because from the identification of that problem comes the awareness and of course the strategy as to how to correct the mental health concern. Correct? Is it postpartum depression? Is it drug abuse? Is it domestic abuse by a abusive partner? So it's hard to actually make a qualified answer without much data. but follow the MAMI intensive care pathway, screening, assessment, support to understand the maternal predicament before we pass a judgment as to whether to separate or not.
Yes,
Drew?
Dr. Mian. Yeah, just to add to that, it's emphasized in the MAMI pathway that all of the interventions are tailored. That is why it's very heavily dependent on the assessment that you have. When you identify the risk factors, it's then when you determine what intervention that you will do. You don't just lump a mother together. That once you think that a mother has a mental health issue, you automatically lump them together and they say that you need to admit them somewhere. It's not like that. And mental health is something that we should all advocate for. It's not something that we should be. It's not something that the stigma should not be there anymore. It's already 2022. So we need to be able to be more open to these challenges that we have. Because as we can see, if these if you think about it, these I'm sure that there were a lot of mother-infant dyads who were not assessed in this particular way, and these are these are opportunities that we missed out on. But now that we know that these are risk factors, then we can now move on and properly identifying these risk factors and giving them the proper treatment.
Right. Thank you. So the emphasis here is really to tailor. So as we say in Filipino, ayaw natin ang dekahon, no? So everything is tailored, and we have guidelines that we can follow to help us tailor these treatment plans for our mother and infant dyads. We're really running out of time. As a time check, it is 9 minutes before 6 o'clock. We had hoped to end our webinar by 6 o'clock. So can we still take questions? Kimmy? All right, I think most of the questions here in the Q&A section, it's about the WHO Z-score calculator, if that is downloadable. That to us was also a new innovation that we had found that was only introduced to us via our partners in Smile Train as well. And I believe there is a link to download this calculator, but bear in mind that the Z-score calculated here is weight for age. And then where can we avail of the MUAC tape measure? Again, this goes back to the question of supply. Ideally, the local government units in your area should be well equipped with something as very basic as a MUAC measuring tape. So perhaps that could be a first good step, though I see Kimmy is typing in her answers to both questions in the Q&A box. All right, so I'm now juggling over back to the chat box. There's a comment here that there's hope that this information that we have imparted is cascaded to community health workers so that we can truly mobilize communities towards this advocacy for the detection of not only the cleft lip and palate, but also for acute malnutrition. And then, there's a question here. Perhaps Dr. Mian, you would like to take this, or Dr. Drew. I'm moderating, so I'm reserving questions for the two of you. There's a question here. If a mother is infected with HIV or pregnant with her baby or next baby, can she still continue to breastfeed? So, okay, I see a hand raised. Dr. Mian, take it.
Okay. Thank you, Dr. Samad Zahid. Yes, HIV and or AIDS are not contraindications to breastfeeding. In this day and age, the mother is put on both the mother and the newborn are put on antiretroviral therapy to minimize, if not eliminate, mother-to-child transmission of HIV. So yes, whether pregnant or breastfeeding, she can continue to breastfeed. It will take a lot to have to stop that mother, especially if antiretroviral therapy is provided for by the state, and the trade-off between for artificial replacement feeding, especially if not feasible, not affordable, not acceptable, not safe and sustainable, or not AFAS. the dangers of formula feeding trump the dangers of directly breastfeeding her baby, even if she has HIV. Thank you for that question. Neither is breastfeeding contraindicated in hepatitis B infection because the hepatitis B virus does not cross into the breast milk. And we
And with
have birth doses of hepatitis B.
I was going to say, with the current COVID pandemic, it is also not contraindicated.
Yes.
During this pandemic as well, for as long as minimum public health precautions are employed. I think that about rounds it out. Okay, so I've gotten the cue from Kimi. So I would like now to give our closing remarks for this really jam-packed 2-day webinar. Dr. Esther Nudoroge Muriti, who is the Senior Vice President of the Global Medical Programs of Smile Train. So I give her the floor.
Thank you very much, Dr. Kapili, and thank you for having me. From the engagement in the chat, I can tell that the last 2 days have been very impactful, and I can see it has been a learning experience and a lot has been exchanged. I wish we had more time. Seemingly, possibly Kimi would have to create another webinar for more engagement. For us at Smile Train, we know, and for all of you, you know that malnutrition is an immediate danger to a child's life, severe malnutrition even more so. But for a child with cleft who undergoes surgery while malnourished, that becomes a definite risk to either complication or sometimes even death. And therefore, we cannot overemphasize the desire and the need to identify children who are malnourished and to adequately rehabilitate them and prepare them for surgery, because then we will be saving a life and we will be ensuring optimal growth and optimal care when they are undergoing treatment. I want to appreciate each and every one of the 293 participants who attended the webinar yesterday and 221 who have attended today. It is a testament to the desire to learn more and to care better for our children born with cleft lip and palate. We appreciate your time. And more especially, I want to appreciate the organizers, the Smile Train Philippines team, as well as KMI, and specifically to our speakers, Dr. Kapili, Dr. Buku, and if I don't pronounce your name properly, I apologize, and Dr. Silvestre. You have invested in the preparation for this webinar. You have invested in the 2 days of lengthy hours to just make sure that our children are receiving the best care possible. For Smile Train, we are deeply committed in supporting our children access the weight that is required for their age during surgery, and for that nutritional rehabilitation. And we do that through grants that enable you to access all the treatment options that you have discussed in the last 2 days, and through educational opportunities like today. So thank you everyone for your care, for your love, and for your commitment to children born with cleft lip and palate. Have a wonderful evening, and for those tuning in other time zones, have a wonderful day and a wonderful night. I'm Dr. Esther Njoroge Mureithi, the Senior Vice President of Global Medical Programs at Smile Train, and I'm dialing in from Kenya. Thank you.
Okay, thank you very much, Dr. Esther. I'm sorry if I mispronounced your name, but it has been indeed fruitful these past 2 afternoons for us here in the Philippines and whatever time zone you're at elsewhere. And thank you very much to all our participants. And we hope to see you soon again, if not in a webinar format, but hopefully as level 1, this is increasingly being announced here in our country, perhaps even face-to-face instances, and see you personally. Thank you very much. And in behalf of Smile Train and of Kalisugan na Mag-ina, thank you very much and have a good day.